There we go. It's working.
All right, so mitochondrial dysfunction in a burn patient. I plan to talk for about 20 minutes. Feel free to interrupt and ask questions at any time. I'm actually not at Indiana yet. I'm in between assignments, so I'm now at the University of Northern Ware, or University of Nowhere. This work was presented when I was at the University of Colorado. Inigo San Millan was the physician who generated all of the data. Matt Godleski is the rehab physician who got us together. I'm presenting the talk because I kept the patient alive. He had about a 30 to 40% mortality when he arrived. So this is the patient, a 53-year-old male. He was, there was a gas leak in his basement, and it had flooded a good portion of the basement, and then a spark and flash flame, and it got most of his lower extremities, both legs circumferentially, thighs circumferentially, backs of his hands. All of it needed to be grafted. He was in the hospital for about a month. Prior to coming to the hospital, he was a near professional athlete, cyclist. Almost could get into the Tour de France, but not as a peloton, but not quite. So as soon as his burns healed, he started going back to his usual activities, bicycling, lifting weights, etc. And he noticed that he had zero endurance. He just couldn't even climb a flight of stairs without getting exhausted. Physical exam showed no focal motor weakness. It wasn't a neurologic problem. It wasn't a spinal cord problem or anything like that. Something more on the cellular level. That's what Dr. Godleski noted, and he referred the patient to San Millan. So as a first step, San Millan put him on a bicycle and measured his serum lactate levels as he was exercising. The data is on the next slide. But I want to tell you that this is a very easy experiment to do. Handheld lactate monitors are easy, cheap. The strips are about as cheap as a glucometer strip. So you could do this on anyone. They just do little pinpricks in the earlobe to measure the lactate concentration. So he just measured his serum lactate concentration at various exercise levels. The slide on the bottom, the axis on the bottom shows the amount of exertion, watts per kilogram. That's just to normalize for body weight. And the watts you can just read off the screen from the exercise bicycle. You know, there's nothing fancy about the exercise bicycle. You can use one at a gym. And an amateur athlete like he was before the burn would generally not accumulate much lactate, even at pretty high wattage per kilogram. Somebody who's an obese type 2 diabetic starts generating lactate at very low levels. And here's our patient. So he went from the green line to almost the red line over 6 months after suffering a 40% burn. The thing about this data that also surprises me is look at these lactate levels. I mean, we're looking at a serum lactate level of 8 or 9. I mean, those are huge. You see somebody in the ICU with a lactate level that high and you think they're going to die. So very high lactate levels, surprisingly.
Dr. Lindberg, you invited interruptions, so I will do so. I have to admit that I would be very happy if I could move to the right and become the red person, because the last time I was on the exercise bike, I had a lactate of 8 at 1.25 watts per kilogram. So keep going. I need to know how you fixed him.
Yeah. Okay, so the next slide. I'm sorry, I apologize. This brings back horrible memories of your first year in medical school. But it's unfortunate that this is the field I have a PhD in, and so we have to talk about it. And this leads into our understanding of lactate metabolism and how we need to think about it differently. We all remember that you have glucose, goes through glycolysis, generates pyruvate, which then goes into the TCA cycle, Krebs cycle, when you have lots and lots of oxygen. You generate CO2, water, complete combustion of the sugar molecules, and you generate lots and lots of ATP. We were taught back then that if you did not have oxygen, this pathway would be blocked and the body would shunt everything into lactate. And that lactate was a sign of hypoxia, poor blood flow, or just overwhelming the body's ability to run the TCA cycle. When you look at yeast, instead of shunting it into lactate, it gives off CO2 and creates acetaldehyde, which then makes alcohol, process called fermentation. And this was also a process done in low oxygen concentrations, but it was very useful for making beer, wine, and bread. Fat is metabolized by going into the Krebs cycle as well. Okay, we'll be coming back to this slide a bunch of times. So in order to figure out where all this lactate is coming from, we took our patient and we put him on a bicycle. But in addition to measuring lactate, we measured his oxygen consumption and his CO2 production to figure out his respiratory quotient, the RQ ratio. And a lot of it's going to key on the RQ ratio, which is the ratio of oxygen and the ratio of CO2 to the ratio of oxygen. And why is it important? It's important because it tells us what substrates we're using. You look at the equations. If you're going to metabolize carbohydrates, you end up generating equal amounts of carbon dioxide and water, and you use an equal amount of oxygen. If you're metabolizing a fatty acid, you actually use more oxygen and release less CO2. So the RQ for fat is less than 1. The RQ for carbohydrates is 1. And you just look at the RQ ratio, and depending on its value, you can quickly figure out whether you're doing mostly carbohydrates or fat. We measured the RQ in this patient, and the results were pretty stunning. His RQ was 1 at all levels of exertion. Never left 1, stayed high. He was only metabolizing carbohydrates. And this just shows the various rate. And it went up the higher he was exercising, as you'd expect. RQ of 1. He was not metabolizing fat at all. He was living exclusively off of carbohydrates and glycogen, which puts him at a pretty severe disadvantage. So why is it happening? Well, it goes back to the lactate concentration. Here's our slide again. Remember, he's generating a lot of lactate. Well, lactate blocks fatty metabolism. It just shuts it down. The details are still being worked out. Some of it has to do on the mitochondrial level. Some of it has to do with fat transport into the cell. Doesn't matter. The fact is, high lactate shuts down fat metabolism. And that's what's going on with this patient. What does the body do when it has so much friggin' lactate? Well, it tries to shunt it off into other pathways. One of the ones is here, where the lactate leaves the bloodstream and then goes back up into glucose. This happens in the liver. It's called the Cori cycle. Husband and wife team, they discovered it quite a long time ago. Look at their equipment. I'm amazed that they discovered what they did with their equipment. And they must have used tons of liver to get these results. The problem with the Cori cycle is that it will not clear the lactate. It only covers about 50% of it normally and only 20% when you're exercising. So the remainder of the lactate is actually being used as an energy source and as a food source. So lactate is not a waste product. Lactate is a food source. That's the first thing you need to think about. Cardiac muscle in the tissue can live on lactate as a fuel source. Spermatozoa, neurons, they live on lactate. Mitochondria can metabolize lactate. We'll skip this slide because this is just a cartoon. We're still figuring out the details. But the bottom line is, we know that some of the lactate goes into glucose through the Cori cycle. Most of it is now being fed into the mitochondria, into the Krebs cycle. And it makes sense. If pyruvate is converted into lactate, it's a one-step process. Why can't it just go back the other way and then go right into the Krebs cycle? That's what happens. Lactate is released in the serum. Heart muscle, brain, other organs will take the lactate, shove it into the mitochondria, create pyruvate, and then put the lactate through the Krebs cycle. So in the nervous system, lactate is a food source. It's also a regulator, and it's a sensor for organ damage in the brain. We think in our patient that pathway was blocked, and that's why his lactate accumulated to such high levels. So how do we make him better? We started an exercise program. This is with San Milan and Nigo. And we just tried to decrease his lactate levels with exercise. He started him on a bicycle every day, aimed for 1 to 2 watts per kilogram, and just had him working that. I don't know how many days a week, but that's what he did over a year. And then he measured lactate clearance and substrate utilization over time. These are the results of that. First of all, at 6 and 8 months, which is the white and yellow, you can see he's still generating high concentrations of lactate and still getting tired. It's not working yet. However, 6 months later, 12 months later, there was some improvement. His lactate levels went down a little bit, and he was able to tolerate higher levels of exertion. So he got better. We don't know why he got better. Still working it out.
So Gordon,
Yes.
between April and June, I assume that those results are within the confidence level. Because,
Yeah, I'm assuming so as well.
Yeah, because he actually went the wrong way for a little bit. But at any rate, I'm sorry to be such a weenie, but this is like super, super interesting.
Well, no, I mean, and yeah, you could see like the difference between these two values is 0.3.
Yeah.
Yeah, so this is all, yeah.
Where is this in line with his skin healing?
So his skin was healed when he left the hospital. He still had some hypertrophic scarring a little bit when he left. And a year out, pretty much the grafts have softened up. he didn't have that many problems with contractures.
I like the inflammatory angle.
Yeah, it is a good point. Inflammation, they've shown that IL-6 can be produced up to 6 months to a year after a burn. Let's see. Oh, and this is now the graph that we had before, where we're looking at carbohydrate utilization, fat utilization, and you can see that at low exertions, he's able to utilize fat now because his lactate isn't so high. But as you exert more and more lactate's generated and his fat metabolism shuts down. So it's still happening, but it's just been shifted to where he's not as sensitive, he's not generating as much lactate, and therefore he can start to use some of his fat.
Gordon, you can probably back into about what his highest specific power was before he got burned. You don't have test data on him before he got burned, right?
No.
But you can probably, I mean, he probably knows from exertion levels and speed, like about what kind of power he could pull. How recovered was he?
Oh, well, what we can assume, sorry. Remember, he was a amateur athlete. We're assuming that he was down here.
Sorry, I'm talking
Before.
to you, not, oh, this is very helpful, sorry.
Yeah, I know, I don't need to make you dizzy. Okay, so now we're just going to broaden the discussion out. Yeah, I'm on time. In general, we've discovered that burn patients have problems with aerobic metabolism after recovery. This was just a clinical series of patients done in University of Texas. They just noted decreased exercise ability, and they did measure some lactate levels in this paper, and some of the levels got as high as 7, not as high as our patient, not as dramatic, but this similar kind of thing was going on.
Dr. Lindberg, can I interrupt you?
Sure.
Yeah, I'm Dr. Mahesh Prabhu from India. I'm a plastic surgeon. And I was going to ask you the question, was your patient unique? And now that you're showing that this is not something unique, but it does happen. Your patient was a mature athlete, but for an ordinary patient who's not an athlete, you know, his mitochondrial function, as per what you're saying, does go down, I suppose.
Yes, and this paper is just looking at normal people. And
Yeah.
Like I said, the lactate levels in some of these patients got up as high as 7.
Yeah.
I think that I should have mentioned this at the beginning. This talk is not going to answer questions. It's just going to generate discussion. We have a pretty dramatic phenomenon that we discovered in one patient, and it seems to be applicable to other patients, and it fits in well with our newer understanding about lactate metabolism. And Dr. Sandalan will be presenting more of that.
Gordon, I'm going to put on my Leventhal hat and go to mechanism. Was there an inhalation component to this guy's burn injury?
No.
Okay. So it wasn't like he got a big dose of cyanide or something like that that would kill his electron transport chain, as far as you're aware.
No.
Right.
No. So what can we understand so far is that he had excess lactate accumulation. Let's just stop here. What we've learned from lactate studies is that when you have a lot of lactate building up in your system, it's not because you're generating huge amounts, it's because you're not clearing it efficiently. That's what's happening with this patient. And we think that the defect is in the mitochondria of his muscles.
What experiments are you planning to test that hypothesis?
Well, we just need to repeat this observation on lots and lots of patients to figure out what's going on. Other physicians, let's see, yeah, it's here. This paper looked at mitochondrial gene expression and gene localization in mitochondria in burn patients, and they saw large numbers of changes. And they weren't able to do anything more than that and just say, hey, we're seeing a lot of changes in the mitochondria. Some of them are involved in lactate transport protein. Some of them are involved in lactate processing proteins, but the details are still murky.
Is there a way of measuring mitochondrial depolarization and other mitochondrial functions in vivo that could be correlated with change in the lactate level in an animal model?
There are some, well, this experiment was actually done in mice. So yes, obviously we can't do it in people.
No, you can't do it to people. No.
Not yet, but I mean, maybe with some of the fluorescent dyes that we have.
Right.
And calcium monitors.
It would seem to me like this is a bigger problem in sepsis and in bad injury across the board.
Yes, it is. And that sort of goes into this last part here. I'm trying to see if I should stay on this slide or go to the next. Let's go to the next slide. So yeah, for decades, maybe a century, we've associated with high lactate levels with poor outcome in septic patients. There's papers showing that if you have a medical patient with a lactate of 4, he's got a 20% mortality. And that if we resuscitate these patients, their lactate clears and they do better. And that all fits very nicely in a low flow state model. And I am not suggesting we change how we do resuscitations. They work, the marker works. We have the data, it works. What I'm saying is that maybe what's going on in septic patients is that the lactate is a marker of some disease process going on in the background that we don't understand yet. And that what we need to do, we have to get into the weeds and the biochemistry and figure it out. There's a number of theories that are out there. One is that the catecholamine surge that you see in septic patients causes glycolysis to start rip-roaring at an enormous rate. And we certainly do see evidence of glycolysis disappearance in trauma patients. You put an ultrasound on their arm, their muscle glycogen is gone. And so you're generating lactate, you're generating pyruvate at an incredibly high rate because of the catecholamine surge and simply overwhelming the muscle's ability to metabolize it. That's one theory that's out there. Other theories just talk about mitochondrial dysfunction and inflammatory changes. And usually at that point, my eyes blur over and I'm like, yeah, right. That's what we always say. Give me some details. We're still working on it.
What are the physiological consequences of the high lactate in this patient?
We think that the most, for this particular patient, we just think it shuts down his fat metabolism. Okay, and that the problem was the mitochondria. Now he got better, so it wasn't a permanent mutation. If it was a injury to his mitochondria, either that injury got better or other parts compensated, because he did get better. The other thing that we don't know about this patient is, did he need the exercise? Because we have no control. So if we're gonna, be critical of his work, we do have to ask that question. Would he have gotten better without the exercise? I don't know.
So
I don't
those
know.
people in Texas that published the incidence paper that you showed, which is really helpful, they don't have a follow-up to see what the natural history is of like burn patients just sort of hanging out, going about their lives to see how it decreases.
No, but there are other papers that show that with exercise, patients get better, but that's all they've shown. They haven't looked at lactate. They haven't looked at mitochondria. They've just shown that, hey, if we exercise these people, they can get better.
I think
Can
the
I interrupt?
exercise program and the monitoring of the lactates is actually key to understanding the problem. We have to assume that there's some threshold of burn injury that is associated with the emergence of this problem, but it's not every patient. Obviously, clinically, we don't see impaired exercise tolerance in every patient who undergoes a burn, or even those patients that undergo major body surface area burns. There's got to be something else that's selecting these patients for the impairment or is associated with the impairment, and may in fact be a preventable trigger in the earlier parts of the disease, but we only have to know how to isolate these patients and study them with the exercise program and the lactate monitoring. The other question I would ask along that line is the impaired lipid metabolism associated with any chemical markers in the serum, such as very low density lipoprotein or triglyceride levels?
This field is too new. I can't answer that question. Dr. San Milan may have some insight into that. We're still not 100% sure why lactate inhibits fat metabolism. We do know that the transporter for lipids into the cell could be affected by lactate. And then also, like I said, some of the enzymes because the pyruvate has to get from the outer membrane to the inner membrane, and that may be affected by the lactate. So it's all still being worked out. I agree that we expect this to be worse with the larger injury size. Certainly muscle wasting has to be accounting for part of this, because I'm sure that the muscle in a normal person is what's metabolizing all the excess lactate. And with muscle wasting, you lose that. So yeah, these people have been metabolically crippled on more than one level.
Especially
Yeah.
vetted patients, especially the diaphragm, right? Because that wastes very quickly, and that's one of the problems that we have in ICU patients after big injuries.
Yeah, I agree. And one of the things that I've seen I've been taking care of COVID patients all year, and that's why I haven't settled down yet. But one of the things that I see people do is they want the ARDSNet protocol on these patients, 6 cc's per kilogram, and they do anything and everything to lock that patient into that protocol, including paralyzing them and Versed drips and everything. And I think they're doing them a disservice. I think they need to let them use their diaphragms instead of enforcing an ARDS protocol onto them when their body just doesn't like it. Other questions, let's see. Oh, we talked about the sepsis model for where we think lactate may be coming from now. If lactate is a food source and a legitimate metabolite, not a waste product, why do our muscles hurt? We don't have an answer yet. We don't think it's the lactate. It could be accumulation of calcium or phosphate. Those are the ideas that are out there. The acid, everybody attributes it to the lactate, but if you draw the chemical reactions in detail, you discover that glycolysis releases acid as well. So for each molecule of glucose metabolized, you release 1 proton. So
Small question.
everything is being re-examined.
You talk about muscle pain.
Dr. Leventhal, we're running low on time, and if you could continue your questions with Dr. Lindberg by text, I'd be very grateful. This is a very thought-provoking topic. We've got a bunch of people on this in this meeting who know a lot about resuscitation. Dr. Kelly's a member of the Shock Society, as I'm sure is Dr. Simpkins. But we have to move on to Dr. Munz's call. The good thing about this is I bet you Dr. Lindberg will try to be on this afternoon when Dr. Sam Milan talks, because those two talks fit together hand in glove. Thank you very much. This is fantastic stuff. And I hope to get as good as your red person someday.
Yeah, and I just want to throw out, it doesn't really change our resuscitation protocols. I mean, they work. It just changes our understanding of them.
Okay.
And in the
Excellent.
future, maybe we'll find some things that may augment the resuscitation protocols. Okay. Thank you for your attention and thank you for your questions.
Our next speaker is in Germany at the moment. Norbert Munz is going to be talking about conservative treatment of traumatic fractures of TL spine.
Okay, let's talk about trauma in spine. And first, greetings from Germany. We have 8 hours time change and 40 degrees on the Fahrenheit scale. No snow, no ice.
Yeah.
In Germany, we have about 8,000 fractures of the thoracic and lumbar spine every year. In more than 2/3 of these cases, the thoracic transition, especially the 11th or the 12th, and the thoracic vertebral body or the first of the lumbar vertebral body is affected. We use in the German-speaking country, we use the classification from the Arbeitsgemeinschaft Osteosynthese. Do you know it? RO, Arbeitsgemeinschaft Spine classification, has been established to classify the different fracture types. In this process, the fractures are classified as compression fractures type A, divided into flexion distraction fractures type B, and highly unstable dislocated fracture type C. A complete cross-sectional system was in 2%, and the incomplete neurological deficit were observed in 11% of patients with type A fractures. I think it's not so difficult to understand as I talked before, but we have A0. A0 is a bone bruise. Is a bone bruise, no fracture, only bone bruise, only fluid in the bone. Then we know it, everybody, the plate fracture, the cover plate fracture, one motion segment. When you have 2 plate fractures, you have a cleft fracture, is A2. A3 is a burst fracture, but the posterior edge is intact, and a complete burst fracture, the posterior edge is broken. Then the next with B1 is a chain fracture, only you have a fracture through the bones. B2 is a flexion injury when you have, or mostly the lesion is in the dorsal ligament, and extension injury, you have a lesion in the front of the ligament. And C is a fracture with high speed, with a dislocation of the spine. Let's see the next slide. Here you can see it's on a picture, but it's only in German, yeah, to understand. When you go on the right side, A0 is only bone bruise, it's nothing. One fracture of a cover plate, one is A1. When 2 plates are broken, you have a cleft fracture. When the posterior edge is not broken, you have A3. And when the posterior edge is broken, you have A4. B1 is only bone, the bone is broken. and B2 is with ligaments, and B3 is hyperextension, fracture.
It'll take me a while, but I'm getting out.
Please translation. It's a very difficult to understand. I think in the United States we have more the classification by McCormack. Is that right? Type A, we heard before, effect to the anterior column, and we saw the difference. Now where's the next slide? Let's see type B injuries is destruction injuries, flexion and distraction, hyperextension. We heard it about. Type C is a very bad injury. Let's see some pictures. You know it. This is only what you say. This is a lumbar spine, no fracture, and it lost his typical alignment. This is A1, no bone fracture. Here you can see this is A1, the fracture of cover plate, fracture of the cover plate. This is in most of the cases. Here you see a cleft fracture, A2. Here's A3. Here's a posterior edge is not broken. Here's a posterior edge broken. Here it's A4. B1, this is a chance fracture, is only bone. It went through the spine. Here's a B2 with a lesion of the ligaments. And C1 is very horrible. Now, indication, when will you do operation? When can you do a conservative treatments? Conservative treatments when you have a type A0 is type 0 fractures, you have no bone fractures. Type 1 fractures with a tolerable alignment, and type A2 without relevant disc damage and fracture dislocation. Only these types you can do a conservative treatments. The other types must get an operation. You must do operation. We know it all when you have neurological deficits, when you have a kyphotic alignment over 15 with 20 degree, or you have a scoliotic malalignment over 10 degree. Immobilization for the pain that is refractory for therapy, relevant traumatic damage to the intervertebral disc. Now let's go to the other slide. In many cases of conservative therapy, approach is possible, which also provides promising long-term results. However, the type of conservative treatment is mostly insufficiently defined. And now we came to our study I will present. The aim of this study was to systematically see in the literature of the conservative treatment of traumatic vertebral body fractures with the aim of establishing a standard concept for the conservative treatment of traumatic vertebral body fracture of the thoracic and lumbar spine. It was a literal search. The method is a literal search, includes a fresh body fractures 4 weeks old of thoracic and lumbar spines of adults with adequate trauma without neurological deficit, persons younger than 18 years or older than 33 years were excluded, as well as patients with inadequate fracture event like osteoporosis. In the literature, search was carried out, including, I can't see it, let me see. Sorry. The literature search was carried out, including all articles to February 18. We used the database PubMed and Web of Science core collection. The question was comparison, conservative, operative treatment, possibility, establishment of therapy, recommendation, what is the best for the patient, diagnosis of vertebral body fractures, primary and follow-up, auxiliary orthosis supply from the orthopedic dealer, drug therapy, non-drug therapies, alternative treatments. In the literature was found 3,345 abstracts, could be called up in the course of the literature search. Of these, 3,170 articles could be excluded. A total of 175 articles were examined more closely. Of these, 140 could be rejected because of insufficient definition. Last not least, only 33 original papers from 1969 to 2018 was or were used. Here you can see all the articles that was used. Initial diagnostics. After high energy accidents, a spiral CT scan is required according to the S3 guidelines for polytrauma and surf injury treatments. In Germany, we use like you guidelines. They call it only with a here with S3 or S1 or S2. After accidents of low speed, conventional X-rays are usually sufficient. You need no CTs, only the X-ray. Standing up to access the kyphosis angel, a CT scan in the affected vertebral body section is recommended. In the different cases, or in the when more is broken, in the case of burst fracture, MRI scan is indicated to ensure the safety of the dorsal ligament apparatus and the damage to the intervertebral disc. I think at this time we made every time MRI in every cases. Additional MRI scan can present the following risk factors for follow-up examinations after conservative therapy: lesion of the anterior longitudinal ligament, cover plate lesion with the intervertebral disc involvement, a pronounced vertebral body edema like bone bruise, diagnosis for the vertebral thoracis and lumbar spine, trauma, CT scan for high-speed accidents, otherwise conventional X-rays. I said it before, conventional X-rays in standing position. In case of suspected fracture, a CT scan is performed. Radiological follow-up after mobilization, after 3 and 4 days, and after 1, 3, 6, 12 weeks. In case of burst fracture, MRI is indicated to exclude a B component and the damage to the ligament disc. The determination of the bisegmental kyphosis angle can you measure on a conventional X-ray. Results. What is with the orthesis? 3 randomized studies on these topics were found in the literature, only 3. However, in all 3 studies, no significant difference in the outcome parameters was found. That means I think we need no orthesis or bandage in the rehabilitation of the trauma spine. Only in isolated or in some cases could be the orthosis have an energetic effect. What about the physiotherapy? There were found no evidence-based studies on the indication and of the effect of physiotherapy for vertebral body fractures of the thorax and lumbar spine. A positive effect could only be achieved in osteoporotic fractures, but the osteoporotic fractures was in this literature excluded. Only early function therapy fractures significantly reduce the length of the stay in hospital. Also for the benefits of physical therapy, such as heat and cold application, ultrasound, current stimulation, and so on, magnetic field, acupuncture, no positive benefit could be shown on an evidence-based medicine. This means physiotherapy should not be good or has not a good result for the rehabilitation of the spine patient. What about the drug therapy? What about the painkillers? The evidence-based data on pain management of traumatic, thoracic, and lumbar spine body fractures is very limited. Therefore, as before, no recommendation can be made on the basis of a systematic view. However, the WHO scheme of pain therapy known, you can always be used. Discussion. The evidence on conservative of traumatic vertebral body fractures of the thorax and lumbar spine is poor. We had only 33 lectures we found. In the future, further studies are necessary, especially in this area. Type and duration of physiotherapy, duration and extent of restriction of lifting and heavy loads. Energetics forms, is there advantage or is there not advantage? Timing and frequency of radiation control in relation to potential therapeutic consequences. Summary. The primary diagnosis to be performed is a conventional X-ray. If a fracture is suspected, a CT scan is indicated. In the case of burst fracture, incomplete or complete, it depends from the posterior edge. An MRI scan is indicated. Conservative treatment is only performed with type A, A0, A1, A2, without a corset or without a orthesis. Orthesis therapy may be appropriate in individual cases or have an energetic effect. An evidence-based effect of physiotherapy could not be demonstrated. Radiology following up in standing position after mobilization and after 3 and 4 days, and after 1, 3, 6, and 7 weeks are recommended. Thank you. And this, you can see, is a nice view from St. Moritz to the frozen sea. And on this lake is every year a famous horse racing. I think we have a similar talk with Dr. Gill a little bit later, and I think he can explain more details for the operation technique.
Thank you very much. That was an excellent talk, Dr. Williams.
Okay, thank you. Thank you.
So, Dr. Munz, this is an enormous amount of work. I was surprised, I guess, given our reliance on corsets and physical therapy, that you weren't able to see an effect in your review. Is this a problem of lack of standardization, small studies, they don't actually work?
I think we must do more
You're
stuff.
muted.
Oh.
We're not hearing you, Dr. Munz.
I think it's important, you know, you can
Okay. Ed?
Dr. Munz,
Yeah.
do you have any experience on the analgesia side with percutaneous kyphoplasty or other percutaneous techniques to control the pain of acute fractures?
No, I have no experience. That's
a technique that's becoming more popular in the States now.
Oh, yeah, I know. I think it's interesting that we can do when you have a 1 or a 2 lesion of the spine, you can do it in a conservative treatment. Otherwise, I think you must operate, or you must do your with a kyphoplastic, with a kyphoplastic. When the ankle, when the scoliotic and the kyphotic ankle is not so much, you can keep conservative. Otherwise, you must do an operation. But I myself, I have not so much experience with operation. You must ask Sonny Gill later.
Thank you.
It's a difficult topic, and sufficiently so that we will return to it. Our next speaker is in the queue. John Marinaro is an emergency physician who holds a host of fancy titles in New Mexico. Came to my attention because I was trading call with him at shock trauma. We were in the same class together. And he knew all about Hanta fever and other exotic things that I didn't know. He's agreed to join the group and will be addressing us on the cure for the common code. I'm quite curious as to what he actually has up his sleeve. John, if you're out there, go ahead and share your screen.
So hi, I'm Dr. John Marinaro. I am from the University of New Mexico. I am co-chief of the University of New Mexico Center for Adult Critical Care, director of the University of Hospital ECMO program, and director of the HELP program, which is the Heart Embolism Lung program of New Mexico. And I was with Dr. Watkins out at Shock Trauma as an emergency medicine critical care physician back in 2003 or 4 or something like that. And so it's been nice to reconnect with Dr. Watkins and to get back into this. I thought I would set up my background as a little bit of a ski lodge here down in Albuquerque, although it's going to have a high of 60 today here in Albuquerque. I thought a fireplace would at least kind of encompass the ski lodge feel since we're not there. So today, again, we're going to talk about a cure for the common code. And we're going to talk some of the literature around cardiac arrest, a little bit in the operating room. I tend to talk more about in-hospital cardiac arrest, out-of-hospital cardiac arrest, but there is some relevance to the operating room and to, I even got a case that involves spine trauma that we'll talk about so that you guys can kind of have a gist for what's going on here. So I am a paid consultant for Cerebell, the EEG company, and I have no conflict with this talk. So in winter of 2016, a 36-year-old woman presented to the operating room for a cholecystectomy. At about 2 in the afternoon, she suddenly became hypotensive while in the OR. There was a prolonged period of time in the operating room while trying to get the ICU where she was hypotensive despite massive pressors. They brought in a TEE probe, echoed her, felt like there was a clot, one of the cardiac anesthesiologists. The cardiac surgeons were like, I want a CAT scan to confirm PE. They brought her down to the CAT scanner. She coded in the CT scanner, brought back up. The cardiac surgeon at that time decided to place an Avalon, which is a veno-venous ECMO cannula, as opposed to doing veno-arterial for her PE. And from about 4 to 5 hours from the time she hit the door to the time she died, it was just a cluster because we were not ready for it. Let's fast forward basically 11 months later. We had a 61-year-old female who flew from Haiti to Albuquerque, drove from Albuquerque to Denver and back. And then she came into the emergency department saying that she was short of breath and having chest pain. So while talking to the ER doc, she cardiac arrested. CPR and ACLS commenced, and we activated our ECPR team. 4 French sheaths were placed immediately, while Lucas, which is a mechanical compression device providing CPR, was provided, and we rapidly cannulated her in the emergency department for ECMO. She survived. This was a in emergency department cannulation, in the afternoon of a patient 11 months after having a perfect cannulation opportunity in the operating room with all the supplies, all the stuff, cardiac surgeons, everything you need, and in a kind of an austere environment of the emergency department compared to a perfect environment of the OR, we got this lady to survive. Now, this lady did actually end up having a liver laceration due to the CPR and having hepatography, as well as a lot of other procedures, a massive transfusion. I think she got 50 units of blood, et cetera, to get her through all this because of the liver injury from the CPR. But we got her through. And as trauma surgeons, that was a trauma surgeon that got her through this surgically, all while on ECMO. Here's another case, a 66-year-old man who had a 1,200-pound crate fall onto his pelvis. He had a vertical shear pelvis fracture along with pubic symphysis widening, bilateral pneumothorax, bilateral rib fractures, a number of vascular injuries all occurred. You can see his pelvis here. You can see his spine fracture here. And while after undergoing his posterior spinal fusion with orthopedics, he was being transferred from the OR table and back to the bed, and he VFib arrested and was defibrillated multiple times, went into asystole. He was cannulated 45 minutes into his cardiac arrest in the operating room, and he went to the cath lab where he had a significant cardiac coronary artery disease that was treated with drug-eluting stents. Soon after, we put him on veno-arterial ECMO. He had return to pulsatility. He woke up, followed commands that night, was on ECMO for 24 hours, was decannulated, went to the OR for his X-fix and got that done, and he woke up. So we have having these people who repeatedly die in the operating room, and they survive when you are able to rapidly put them on ECMO. Now, we've actually had a lot of lives saved. This lady cardiac arrested in the Walmart in Albuquerque. This lady on the bottom left here, cardiac arrested at another store in Albuquerque over the Christmas holiday. This guy here in the middle, cardiac arrested. That lady was the one I showed you originally. And here's another guy who that's that other guy we showed you that cardiac arrested. We've saved, dozens of lives using very little resources to implement our ECPR program. So let's talk a little bit about it. And again, I'm going to talk a bit about the operating room cardiac arrest, but this talk tends to gear for out-of-hospital cardiac arrest, which occurs 350,000 times a year. About 70% of the time it occurs in a home or residence, so you don't really see it, but it occurs in a public setting about 20% of the time. Over 50% of the out-of-hospital cardiac arrests are not witnessed, so there's not really a group of people we can help, but other 50% are witnessed. Only about 39% of the time do they start CPR, and a shock is delivered after an AED is placed only about 2% of the time. 90%, this is not changing, 90% of all out-of-hospital cardiac arrests die. So we're only saving 10% neurologically intact, or actually 8.4% neurologically intact survivors. If you watch TV, you think everybody comes back. But if you have an out-of-hospital cardiac arrest, only 8% of those people go home. And that needle has not really moved since around 2000, and we'll talk about that. 73% of these people die from neurologic failure. You get their heart back, but 3/4 of them are all dying because we can't get their brain back. As a matter of fact, if we look at the data on who we can get back, if they don't respond in about 16 minutes, less than 1% of out-of-hospital cardiac arrest patients come back. So if you're defibrillating them at minute 0, you might get them back a good percentage of time, and it keeps going down. It's really impressive that at about 15, 16%, it nearly becomes futile to keep going on out-of-hospital cardiac arrest. How about the operating room? Well, the operating room is much better. Here's 2,500 cardiopulmonary arrests that occurred in a review that was published in Anesthesiology in 2013. And about 31% of cardiac arrests in the OR survived to discharge. If they were VTAC, VFib, 41% survived, and obviously that makes sense. These are people who went down, they were immediately defibrillated in the operating room. About 30% of asystolic people, that's actually that's well more than triple the survival of out-of-hospital asystole. 26% of the pulseless electrical activities actually survived to discharge in this series. And you think about it, obviously, in your patient population as surgeons, a lot of your PEA is probably exsanguination, and that the anesthesiologist got behind, and you guys and you could get them back with that. But those top 2 categories are probably the sweet spot for being more aggressive in the operating room. Survivorship, again, after asystole is 30 to 50%, compared to just even inpatient, forget out of hospital, which is about 10%. So you can really do a lot in the operating room when a patient of yours cardiac arrests. So if you look at this cardiac arrest algorithm published in this 2018 paper, they basically list as one of the things going to ECMO. But a lot of your programs probably don't have ECMO set up to be rapidly deployed. You have all the other ACLS stuff, which we're going to talk about, but getting to ECMO in some of your institutions may be a stretch, especially to be able to do from time of arrest to being on ECMO in less than 60 minutes, which is the industry standard to save the most amount of brains. And the quicker you put a person on, the better odds their brain will survive. As a matter of fact, Dr. Yiannopoulos out of Minneapolis has 100% survival for ECPR on out-of-hospital cardiac arrest if they get on in less than 30 minutes. But the industry standard is you should get them on within 60 minutes. The operating room is always a little bit more time because of the fact that they have good CPR and they're usually being ventilated. So the AHA came up with the chain of survival for out-of-hospital cardiac arrest. It involves recognition and activation of the emergency response system, high quality CPR, rapid defibrillation, ALS and or B and ALS, and then advanced support when they get into the hospital. Let's talk about each one of these things to see if they actually make sense. So recognition and assessment, the first chain is recognition and assessment, but it's interesting how difficult it is for lay people or even doctors to recognize that somebody is suffering a cardiac arrest. Some of these cardiac arrests can be associated with just, is it a fainting or are they seizing, and they don't really know. Individuals can keep breathing for several minutes after cardiac arrest. As a matter of fact, a tape of 100 EMS recalls estimated that about 30% of the patients who were there, they could still hear the patient gasping in the background, thereby making people think the person wasn't in cardiac arrest, thereby saying, hey, we're not going to start CPR because they're not in cardiac arrest. People often think people are just, they think they're awake and they're seizing, and they think that they're still breathing, and so they don't start CPR. As a matter of fact, there is was a great talk I went to at the Canadian Critical Care Conference about just before the pandemic, actually, where they looked at all of the social media video platforms, YouTube, and I'm not a social media guy, but all of the things in closed caption TV that captured videos of people cardiac arresting. And what they found was they labeled out all the symptoms people had just before cardiac arresting and then just after cardiac arresting, and the amount of people that just stood around and didn't do anything thinking that that person was still alive but really they were in full cardiac arrest. I have another video when I give this talk, and I have more than 30 minutes to give, of a NBA player playing for the Canadian Basketball League, ESPN televised, and this guy, cardiac arrest, one of the basketball players, cardiac arrest on the court. And paramedics are there, the team doctor's there, everybody's there, and they're treating him as a spinal cord injury and not starting CPR because he was down, but he probably had IHSS, cardiac arrested, while playing basketball. And he actually went on, they didn't start CPR till they were in the ambulance, and he was in cardiac arrest the entire time on the floor. They cut to a commercial, came back to it on ESPN. He's still lying there on the floor. People are doing spinal precautions, loading him on, and nobody checked a pulse on this guy because it just didn't make sense that this guy would suddenly cardiac arrest. He went on to die, and the family sued the paramedics and the NBA, or not the NBA, but it's like the Canadian NBA, because nobody did anything for this guy, even though he was in full cardiac arrest. It can be very difficult to recognize. But if you recognize people, you can activate the chain of survival and get to the next level, which is immediate high quality CPR. If you do immediate high quality CPR, you can increase their survival rate from 50 to 500%. As a matter of fact, in this other study of 142,000 patients, there was a 4-fold increase in survival rate by getting bystander CPR getting going. And the number needed to treat is only about 24 to 36 patients. If you think about aspirin for acute coronary event, you need about 50 patients for aspirin to make a difference. Yet we all have aspirin drilled into us. We should be starting CPR, effective CPR, really rapidly. If you don't do CPR, but you just hold out for ACLS, you're going to get people back, but they're going to have bad neurologic outcomes. ACLS without bystander CPR just creates a lot of brain dead people, which may be good for donation, not very good for getting the people out of the hospital. Hands-only CPR works really well. You actually do not need to breathe into people's mouths. If you just do CPR, you actually increase the rate of CPR pretty significantly, from 28 to 40%, by just telling people to push on the person's chest, doing good high-quality compressions. If your initial PaO2, now I'm in Albuquerque, so my initial PaO2 is only 80. For those of you at sea level, your PaO2 is probably 100. When you start compressing on a person, you still have about 5 minutes for that person's PaO2 before it's going to fall substantially enough that they're going to have anoxia, versus just giving them flow with their oxygenated blood. And so I think it's really important to realize that you are pushing the limits of getting bystander CPR going, even without the mouth breathing in the era of either COVID or all the other diseases that one can catch by blowing into someone's mouth. So it's really important to do high quality CPR. How about rapid defibrillation? Well, cardiac arrests that are caused by VTAC and VFib can be treated really well by an AED. A matter of fact, I just had a patient last week who was flying from the Green Bay Packers game through Albuquerque to Austin and cardiac arrested on the plane. And while on the plane, he had 30 minutes of CPR from a nurse on the plane. Southwest landed here in Albuquerque, and on the plane, they were delivering AED shocks. They got him back, got him to the ER, intubated him, but he had 30 minutes of CPR, and we took him to the cath lab. He didn't go on ECMO, but he woke up and was extubated the next day. AEDs work, CPR works. If they can recognize early, be applied early, do a good job of it, and get the shocking. The thing is about AEDs is that you have to shock really early. And if you shocking VTAC, it's going to work well. Shocking VFib, it works a little less. And clearly you can't shock asystole. Here's some great data looking at the benefits, looking at total cardiac arrest numbers. If you are in VTAC and VFib and get bystander CPR, you actually have about a 30% survivability. If you have VTAC and VFib and you don't have bystander CPR, it's still pretty good. It drops to about 27%. But if you have asystole, you have like a 4% survival. PEA is about 7%, and all comers, all numbers, it's about 10%. But you can see we haven't really moved our numbers that much on all cardiac arrests since the early 2000s. And so it's really, really important to realize that we're not moving a lot. We're spending lots of money on a lot of research. Amiodarone came out during this period of time, a lot of different things, but we are not making progress on getting patients to survive after cardiac arrest. This is the study. Paul Pepe and Lance Becker both did this study. If you guys ever get to meet Paul Pepe, he's an amazing jazz pianist. We brought him to one of the bars here in Albuquerque, and he played jazz piano till about 2 a.m, with getting all of us completely destroyed and having a great time. He did a great study in 2000 to 2002 when the AED was first coming out. They put AEDs in 3 Chicago airports. There were 21 cardiac arrests that were non-traumatic in the airports. 18 had VFib, 3 non-shockable. So you get down to 18. 4 of the patients were not near defibrillators. None of those patients survived. 3 of the patients remained in VFib despite using the AED, and they continued to die. But 11 were successfully resuscitated. 8 regained consciousness after hospital admissions. So really, you had 10 of 18 patients with VFib were alive and neurologically intact 1 year later. With that control group of the 4 who were not near defibrillators having 100% mortality, you actually ended up having 10 of 14 patients alive a year later, neurologically intact, showing the benefits of that. So it really seems to work. Recognizing the person's in cardiac arrest, starting immediate high quality CPR is super important, and defibrillating them. What about the next step? What about advanced emergency services? So the 4th link, adding ACLS to BLS defibrillation and recognition, is kind of the question. Does that really help? Does it help get people to survive to discharge? Does it help them just get ROS, return to spontaneous circulation, or does it create a lot of people who get their brain back, their heart and lungs back, but not their brain? So they excluded trauma patients, people who are obviously dead, and less than 16-year-olds. They looked at 5,600 patients over 48 months in 17 communities and 11 hospitals. 1,300 or 1,400 actually got no ACLS. They just got the rapid defibrillation, but no advanced cardiac life support drugs. 4,300 got advanced cardiac life support. Typical thing, epinephrine, atropine, lidocaine. And there was no difference in the rhythms between the group. What did they find? They basically found that there was absolutely no difference in survivability neurologically intact by adding ACLS. Epi doesn't help, lidocaine doesn't help, atropine doesn't count. I imagine amiodarone wouldn't make a difference either. If you do the first 3 chain links of it, you will make a difference. After that, nothing moves the needle on cardiac arrest in the operating room, anywhere else, okay? So there's also a number of papers about showing how giving epinephrine is probably associated with worse outcomes neurologically because it constricts your cerebral vasculature so much. You also get a lot of CPR injuries. Here's a paper that we just got published in the Journal of Artificial Internal Organs in November 2021, showing the amount of injuries we had during CPR. There were essentially 38 patients, 37 patients, 97% of our patients had more than one injury due to CPR. 54% of those patients had to have an intervention. Now, some of the interventions were, they needed to be on BiPAP for their rib fractures, or they needed to be on, they needed to get transfusions, et cetera. Some of them, again, laparotomies, hepatorophies, tube thoracostomies, et cetera. So, the interventions ranged, but they were not benign things. We're not having nothing. Most patients, 71%, had more than one rib fractures. 93% had bilateral rib fractures, sternal fractures, hemothorax, pneumothorax, actually no pneumothorax, pulmonary contusions, liver lacerations, all pretty substantial injuries due to CPR. One of the comments we get is, well, this is because of the Lucas compression device. Actually, only about half of these patients had the Lucas compression device on. So it's not that mechanical compression device. Even paramedic human-based CPR devices or human-based CPR will cause significant injuries. So that is, the first 3 are good. ACLS, not so much, maybe damaging doing prolonged CPR, maybe damaging giving epinephrine. So we propose doing early VA ECMO. Let's move that chain of survival. Let's make ECMO the 4th chain of survival. So what is veno-arterial ECMO? Veno-arterial ECMO is the rapid placement of a 25 French venous cannula and a 15 French arterial cannula, common femoral vein, common femoral artery, respectively. And if you look at it, the extracorporeal life support database shows a 27% survival, tripling survivability with a neurologically intact good outcome, CPC 1, cerebral performance scale 1 or 2. So 1 is completely normal, 2 is maybe you pull to the left when you walk or something like that, but you're still able to be on your own. If you look at the University of Minnesota, like I talked about Yiannopoulos, he's got a 45% of the patients discharged and alive, with 42% of having a good neurologic outcome. Threefold increase compared to historical controls. University of Utah, same situation, where they had great survival rates. How about us at University of New Mexico? We started this in 2017, was our first day of official ECPR, which was 2 days before that lady from Haiti came in. 2017, we actually had a 25% survival. And remember, these people are typically getting cannulated between the 50th and 60th minute after cardiac arrest, because it takes just a little bit of time to get everything going. They're being transported into the hospital, et cetera. So it takes just a little bit of time. So these are not people who are failing conventional, I'm sorry, these are not people who we're not trying conventional methods. We are doing everything. They're still getting shocks, getting all the different stuff, but we had 25% survival. 2018, we actually had a 40% survival. 2019, 24% survival. 2020 screwed it up because we didn't do that many of them. We had a lot of COVID patients we were trying to do it on, so it kind of screwed it up. And if you look at our data this year, we've done 2021, we've done 17 ECPR runs with a 52% survivability. So we have 52% survivability by having our ability to do this. If you look at our hypothermic arrests, since we're talking about snowmass, we've had 10 patients, 10 survivors to discharge with 1 death. Now you might be like, wait, that doesn't make sense. Well, one of the guys, and I put him on last Wednesday, he was the second time he came in. He was a homeless guy who came in for his second cardiac hypothermic arrest, 23 degrees. And I put him on for a second time, not realizing it was the same guy, but same guy. And he is home. The only thing that kind of held him in the hospital is he had staph bacteremia on arrival blood cultures. And so we've had 90% survival. One of these guys had 3 hours of CPR. He went to 2 hospitals getting CPR prior to getting to us. We put him on and he walked out of the hospital. Unbelievable. So our algorithm
John,
is
you need to buy that guy a sleeping bag.
Yeah. He also was extremely covered with lice. He had like somewhere around 1 million lice on him. That the first time around, one of the fellows actually had to shave his head. The guy had so much lice, and the guy got lice into his hair. This time, because of COVID, we were much more bundled up, so it kind of protected us. So our in-house, we have an in-house ECMO cannulator Monday through Friday, 8 to 5. This is a purely intensivist run cannulation. No. We do have one vascular surgeon, trauma surgeon, critical care doc who also works with us and actually does a lot of our ECMO cannulation, decannulation work. But this is all EM doctors, internal medicine, just critical care guys doing this, and gals. So about 50% of the nights we have people on in-house, and 90% of the weekends we have people on in-house. We report to all ST elevation MIs in the operating room and all cardiac arrests. We put in bilateral common femoral artery, common femoral vein sheaths. We stop and check to make sure there's no ECMO contraindications, like are they over 75? Do they have metastatic cancer, end-stage renal, end-stage liver, end-stage lung disease? If they don't have any of those things, we put them on, and we cannulate down to 13-year-olds. We stop and, we then place bilateral ECMO cannula and go on. We get a full head, CT head, neck, chest, abdomen, pelvis, actually not a neck, but CT head, chest, abdomen, pelvis. And we go to the cath lab if there's no other diagnosis, PE, they were bleeding out, something like that, that would have caused their death. And so we really propose moving that out of hospital chain of survival over and getting that. But what about pre-hospital? Why are we waiting? Well, in Paris, they have started doing pre-hospital ECMO where they're cannulating people. And you can go online and find pictures of Lionel Lamott cannulating people on the floor of the Louvre, the floor of the Metro, cannulating people. And they've increased their survival from 8% up to 30% doing that. So, man, that is amazing. Forget Paris, Schmaris. We're doing that in Albuquerque. So we got the Albuquerque city to give us one of their ambulances, and we set it up as ECMO 1, an advanced cardiac resuscitation unit. And what we do is we set it up with a hand crank. Forget the $45,000 device. Forget the $120,000 Rotaflow. We just took the hand crank, or CardioHelp rather. We just take the hand crank off the Rotaflow, and you can see it in the picture right there. Put it on this pad we have here with the oxygenator, cannulate, and here's Dr. Detmer cannulating with one of the firefighters helping him. And there's the hand crank going, and we're cannulating this person and hand cranking, getting their flow to 4 or 5 liters. What does CPR get you? Maybe 1.5 liters of flow, maybe 2 liters of flow if you're doing a really good job. So we're cannulating in the back of that ambulance for ECMO. We've actually done 4 cases, 0 survivors, but all of them were on in less than 60 minutes, no cannulation complications. Their cerebral oximeters went up and all of our metrics, their lactates cleared, all this stuff. What we did have, the reason why we're having deaths is because we're only cannulating people who are more than 30 minutes to University Hospital in Albuquerque. So we're self-selecting people who are further away, having less chance, like these people would never have been given the opportunity to get ECMO. So what we've done, and the pandemic slowed it on, we were on again in October, November, and into December, but then we got crushed by the pandemic again. And so we've had to back off it. But we're going to shorten our time and make it anyone in the city who's 15 minutes or more from University Hospital will then be able to be a candidate for this. So we are able to do that. So really what we propose is early ECMO in the field, getting these other things out of the way because they don't necessarily help all that much. So one of the questions I always get is, boy, is ECMO cost effective? Is ECPR cost effective? Well, there's a great paper looking at the quality adjusted life years, the measure of health outcomes. And anything less than $150,000 is considered a worthwhile quality adjusted life year measure. And ECPR costs about $56,000. Our median range of ECPR runs is 3 days. Our median range for COVID survivor ECMO is about 40 days. So it is way more valuable than doing COVID ECMO. We have very good outcomes. Our outcomes for COVID ECMO are worse than our ECPR outcomes. Our massive PE outcomes are 80% for massive PE, whereas we had an 80% mortality before we did ECMO on every massive PE. If you look at it, comparing it to dialysis, it's cheaper than dialysis, it's cheaper than transplantation, and it's cheaper than heart transplantation, obviously. So our DRG, the DRG for ECMO is $112,000 per run. The Rotaflow devices are about $45,000 a device. We actually got 4 of them at $5,000 a device because there was kind of a fire sale going. So we actually even got them cheaper. ECMO circuit's $1,500. Our ECMO pack's $200. ECMO cannula about $500. So all told, to get the person on ECMO is $3,100, less than a dose of factor 7. For those of you guys who use factor 7, much less than a dose of factor 7. So it's really not that expensive to put a person on ECMO. We're not paying cardiac surgeons to cannulate. We're not paying anybody else. It's just us. And, lastly, there's a American philosopher, Daniel Callahan, who actually just died in 2019, who argued the moral logic of medical process. He said, what can be done to struggle against death ought to be done, and what ought to be done ought to be available to all. If we do not, we are open to moral blame. People who die who need not die, people will die who need not die if we do not use our newest available technologies to save lives. We will all be held accountable for those deaths. For their lives, I guess. So that's the end of my talk. It's a longer talk that I kind of jammed into 30 minutes, but I appreciate the venue. I appreciate you seeing Dr. Watkins, and I'm happy to answer any questions.
We're only going to be able to ask one question because of time, but you can ask all the rest when you come here next year, when you're going to talk about implementation. Dr. Kelly from Springfield wanted to know how you got the hospital to buy in.
So it was, the hospital buy-in was not that hard, and believe it or not, the cardiac surgeon buy-in was not that hard. We started ECMO for hantavirus, not me, but the team before me in the mid 90s with cardiac surgeons doing the cannulations and the pediatric intensivists running the program. In 2016, we had a massive PE patient die that all of the adult intensivists felt should have gone on ECMO. We had done maybe 1 to 2 adult cases per year up until then. And then in 2017, when I took over the adult ECMO program, we started putting them on for typical critical care indications. And we went from 1 to 2 cases a year to 25, then the next year 35, the next year 55. Now we're around 60 cases a year typically for all of our ECMO. And so the hospital didn't have a problem with it. The billings are quite good. The cardiac surgeons were very happy to push it off on us and not be involved in it. So they weren't getting called in the middle of the night to deal with this stuff. And we got it set up, and we keep it cost effective, and we really create a lot of goodwill across the hospital by saving patients' lives.
Okay, so a lot of it goes back to that first patient you told us about. This is fantastic, and I'm glad that you've accepted our invitation to come here in person next year to tell us about the program building part.
Absolutely, absolutely. I did just write the opening chapter in the new ELSO textbook on setting up a program, so you could read the ELSO Red Book ECPR book that just came out a month ago, and I'm the author for that chapter. So,
well, that's great, but surgeons, you're assuming we know how to read. But anyway, fantastic stuff, and I was wondering if there was a hantavirus angle, and you answered that.
There you go.
So more. Our next speaker is going to be Wing Commander Pandya, who's calling in from the East Coast, but he normally hangs out in, I believe, Portsmouth. He has a dual appointment with the NHS as well as his RAF appointment, and has a slew of leadership positions that, if I were to list them, would take longer than his talk. Members of this group will know that last year he gave his series of craniotomies, which he did as a plastic surgeon in the field. He's going to be talking about ethical issues. Take it away.
Right. Can you hear me, folks? And can you see the screen?
Yes, yes.
Okay, thank you. So actually, the last talk has very, very beautifully introduced the reason for my talk today. And it's titled A Day Without Consequences. And when we are talking about the moral blame, etc., this talk is centered mainly on triage and patient selection. And we have a lot of intrinsic and extrinsic factors which may influence our approach to patients. These are my engagements and involvements, and all this has stemmed from my multiple deployments to Afghanistan and Iraq. So it's about human factors and ethics in triage in both war and peace. So this is the aftermath of the Boston Marathon bombing. Sorry, all these are basically examples of disasters where the capacity is overrun by the number of patients who require any sort of treatment. And all we are trying to say is that a patient, regardless of where their origin is, sorry, their aspirations, not COVID, by the way, sorry, have similar dreams and aspirations. Sorry, I need an ECMO, I think. So what are human factors? They're relationships between humans and the systems they interact with, and the main focus is on minimizing errors. And the thing I'm concentrating on mainly is that they should create efficient care processes in medical care. These are the factors that play a role in the management of patients, influence our ethical thinking, and they consist of innate and environmental influences. So we know errors occur on a daily basis. And an error is nothing but a deviation from the intended mean of doing something. Errors are not accidental, they are committed. They're usually because of carelessness, lack of knowledge, lack of training. Whereas it's a preventable adverse effect of care, whether it's harmful or not harmful to the patient. Whereas a complication is any occurrence that has an adverse impact on the overall recovery of a patient. So if you look at oops, the guy trying to get through the oops, it's an error. It's an error of judgment in this particular patient. But getting the compression injury to his torso is a complication. And everyone is aware of the Swiss cheese model of human error. And you have multiple organizational issues which eventually create the perfect storm. And we have such a storm in my house. And he's my little dog, Atlas, who loves running away. And as he's grown, he's become a bit of a challenging young boy. And this is the outline of the ground floor of my house. This is where he tries to run away all the time. And if you can see, there are organizational influences over here where you have multiple doors and exits which may open up. Unsafe supervision. Obviously, I'm not going to look at a dog every single day. And unsafe practices. So someone may come with a package. You come inside over here. You need to leave the package either over here or over here, and the dog makes a bolt for it. The airline industry is the most error conscious, and they have SOPs, and they are the ones who have actually created the environment of safety within the medical system, because their pre-flight checks, etc., have now been incorporated into the WHO checklist. So we do it before, during, after any form of surgery, and this has genuinely decreased the number of errors. The airline industry is so safe that since this UK disaster in 1989 and more than 3 billion passengers, there has been no further death due to human error. And this is a 2017, so slightly outdated, from Johns Hopkins, which shows that in the US, medical errors accounted for, it was a third leading cause of deaths amongst patients. In the UK, there are about 4,000 deaths per year due to human error in medicine. And that's equivalent to about 25 fatal crashes per year. So errors should not be minimized, and the impact of those should be recognized. We have innate factors governing us, which are influenced by birth, social standing, gender, nationality, religion. And these are the conscious bias based on the personality of the patient or the individual, and prejudice, judging someone on unjustified or unassumed traits. And we have unconscious bias, which occurs despite our best conscious efforts. And I examined for European and British plastics and hand surgery. And we are given this talk 3 times a year about how, if someone is very fluent in their exam, someone appears to be well-dressed, we suddenly have a softening of any sort of bias against them. So the important thing is, do we think that the person we are dealing with is part of our in circle or out circle? So if you had to go for treatment, would you go to this young lady, might have been starting off in her professional life, or to this scruffy young guy, or this young lady who's got tattoos, or this lady who's of a different ethnicity, or this gentleman who appears to be mainstream in terms of what we expect in hospitals? And the extrinsic factors, we know that this is an optical illusion. We know that there is actually no movement of anything that you see over here. And our work environment is something else that impacts heavily on how we respond to patients and situations. And that's getting to work, expectations, audit scrutiny, but important ones. are the personal factors which create this impact, which is fatigue, hunger, nutrition, emotional stress, situational awareness. This is a photograph from my hospital in an average winter, where there are patients who are lining up for the emergency department. And in terms of personal factors, fatigue is something which affects all of us. Emotional stress is a very important factor in disruptive behaviors, which is seen as a sentinel event in increasing the risk of patient death. And how to control is very, very important.
What a difference a day made.
So you can be a charming doctor who has obviously disruptive behaviors, but the importance of the disruptive behavior is not the impact that he has on the patients, but how they react, or the people who work with him react to him. And we have this thing called HALT. So if you're hungry, angry, late, lonely, or tired, you need to take a stock of what is going on in your life. Over and about that, situational awareness is very, very important. And
He's going for it, pulling up at 400 miles an hour. He now pulls them into short diamond from 955 feet wide. The jets now collapse to be around 6 feet apart. As they
so tunnel vision is something which is a corollary of situational awareness. In this particular video that we showed previously, the situational awareness is completely with the lives of 9 or 10 other aircraft. Tunnel vision, on the other hand, is where you may be so engrossed in your job that you have a problem in picking up peripheral cues. And it's also sometimes called inattention blindness. Now, everyone has knowledge of the gorilla who comes into that little scene where people are playing with a little ball. So this is a different take on it.
I'm going to hide this Hershey's Kiss under this cup. And the object is for you to pay attention and follow along and try to guess which cup the Hershey's Kiss is under at the end. Try to guess if it's in the left cup, the middle. Hands.
Now, this is the same thing being done with multiple cups, and please pay attention to this for a minute or two.
You from the pink cups. The pink cups will always have, one of the pink cups will always have the Hershey Kiss underneath. So let's get started. So can you guess where the Hershey Kiss is?
So this was basically just an example of how when people are very focused on tasks, you tend to lose a peripheral stimulus. And the importance of this, and I'm not going to show the video, is there was a young pilot who lost his wife when when she was undergoing a very routine ENT operation, and the entire staff within the actual operating department was so engrossed on attempting an intubation that they lost all track of time. They refused to take cues from the monitors, from the clocks, from the surrounding nursing staff who were giving them a cric set, a trachea set, any of which could have saved their lives. And the problem with this was a combination of inattention blindness plus the hierarchy which has been created within the operating room, which makes people very scared of speaking up. So you refuse offers for assistance, you're reluctant to take breaks, there's confusion with what's going on. And team working is very much a part of this entire process. So how are you perceived in the hierarchical gradients? And it all depends upon leadership styles. Are you goal-oriented at the expense of people? Are you overbearing, dominant, dictatorial? And a lot of surgeons may fit into this particular mindset. Are you inspirational, visionary? Are people happy to come and approach you? Do you feel that you're approachable? Is it a David and Goliath sort of scenario over here? Is leadership imposed by means of a position, like in like the military or the surgeon or the ED attending? So all these are major issues. Multitasking when doing complex tasks is also a major deterrent factor. And many studies have found that multitasking impacts on hearing, manual dexterity, decision-making, prescribing errors. And this is a classic example of what not to do. Noise is a major issue. And the greater the background noise, the more likelihood for error. And of course, this is a spoof. Cockpit noise has been actually studied, and in dB levels, in general, sounds about 80 decibels are harmful. And this was a recording made in a cockpit. So all these are very important factors when it comes to a person's attention when dealing with any sort of issues. And briefing and debriefing are obviously very important aspects. You have introductions, make sure that you give the ownership of people to speak up as and when required. You identify people's positions, etc. And most important question is what to do if something does go wrong. And finally, in terms of human factors, we have our responsibility of candor to own up to mistakes rather than try and hide them. Ethics, on the other hand, are the moral principles that govern a person's behavior. Ethics should be absolute, but obviously they're not, because they are dictated by various other aspects. And you have normative ethics, which is very ethical claims, like murder is wrong, giving to charity is good. You have deontology, virtue ethics, consequentialism. And ethics are influenced by religion, race, nationality, ethnicity, and education. So why has this talk been given? It's basically to say that every human being is influenced by their innate nature, their surrounding influences, the way they've been brought up, things like fatigue, the environment that you work in, and how does that impact upon your dealing with day-to-day patients. So you have this 15-year-old girl explaining that she's pregnant. And the father of a child is someone she loves. He's 29 years old. She's undecided as to whether she should have an abortion. And she does not wish her parents to know about this. So these are the various things which run through people's minds. This is the young girl. Do you persuade her to keep the child? Now, is that going to be based on science, culture, beliefs, religion, or ethics? Are you going to suggest abortion? And are these same factors going to play a similar role? Are you going to inform the parents? So where is autonomy in ethics in this? Because we have something in the UK called Gillick competence, where a teenager is thought to be Gillick competent when they have capacity to decide as to what's going on. Are there any other concerns that are raised by this young child? She's underage. Is she being groomed? Is this considered a statutory rape? Are there problems with potential STIs? So should social services be involved in this? What has influenced our decisions in approaching this young lady? Is it her religious beliefs, being a left-wing liberal? Is she part of our in or out circle? Is it ignorance? Do we have knowledge of the law in this? Or is it a sound, unbiased knowledge of medical ethics? What if she went to the same school as your child and was a friend of hers? What if she was a drug addict or a refugee from another religion? Or imagine this patient coming at the end of a very long, tiring day when you're in a rush to go home. Do you have the time to rationalize through all these ethics? You have a similar thing with a liver transplant candidate. So you have one donor liver which has become available, 3 candidates. You have this 18-month-old baby girl. She was born after IVF, a refugee child of ethnically and religiously diverse parents. Single mother of 3, on benefits, previous drug user, and a post-alcoholic, very renowned professor in your own university. Now, there are people who might allow external factors to influence the decision in terms of who should get the candidate. We all know that these are dealt by multidisciplinary teams, and there are various factors which get into who should be the right candidate for this particular procedure. And we are not going to allow basic things to influence it. However, if all 3 fitted the bill, who would you choose? And what would your triage be based on? Are these going to be personal factors, ethics, human factors, or things like qualis? Are they part of our in circle or out circle? You have a mass disaster now. The common thing amongst these slides, as explained before, it's a disaster. You have a problem with capacity, infrastructure, expertise. And what is the most important response when there has been a disaster? Of timely response, timely aid, targeted aid, do maximum good with what is available. But who do you direct this towards? And there should be no consideration in triage apart from the basic tenet of doing as much good to those who need it. But because we are humans, we tend to bring in human factors, ethical considerations in this equation. And triage, of course, we know is a sieve system with multiple ways of classifying triage. You have physiological, anatomical systems, you have resus, surgical, transfer triage, and you have multiple casualties and mass casualties. Let's take this young child who sustained burns in Afghanistan. 2 years old, beautiful, 43% burns. NATO doctrine stated that any local civilian with 40% burns and above should not be resuscitated, as it would be an imposition on the resources that we could use for our own soldiers. So obviously she was put on a morphine drip, tube was removed, she passed away in 30 minutes. So was this ethics what we euphemistically call medical retirement, or is this a form of triage? Obviously, it's based on a protocol, but she was collateral damage. And where does the line or boundary between ethical responsibility and triage come in this particular scenario? You have Jehovah's Witnesses, and they believe that blood, once having left, cannot be restored. If it's a child, the child becomes a ward of the court, and we will save the life at any cost, regardless of what the family wish. However, for the adults, we know there are 5 streams of belief. Autotransfusion is fine because the blood is still in continuity with your vascular system. You can previously donate the blood and reuse it. You can use volume expanders. You can use things like EPO, or you can do nothing. So what would you do for a patient like this if they have not come with any firm directives? What principles do you use to treat or manage these patients? And remember, we are talking about these as individuals, but they may be part of a larger mass casualty situation. This is someone I dealt with. This is a son and father. The son was trapped with explosives, loaded a handcart, approached a British checkpoint, and the father remotely exploded the bomb. So we had a large number of casualties who had come in. The Taliban father later on in the day was brought in along with the soldiers. These were the mass casualties, one of the 2 boards that we had at that time. So one of our patients was airway compromise, ischemic hand, injuries. The face was obviously smashed open, limb injuries, multiple surgical teams, vascular repairs, amputations, and we got this patient back. That was the father. Injuries. So we had to spend 8 hours for this Taliban father, prioritizing him over and above multiple US and UK soldiers based on the pure P1, P2, P3. And we made sure that our personal factors did not play a part in the resus of this particular patient. All of us were very happy just to allow him to die if anyone had asked him, because we had 28 dead earlier in the day from what he had done. External fixators. You saw that we put an external fixator on that man. And a lot of the limbs were treated with X-fixes. The problem is, after 3 or 4 days, when these patients went from our holding facility to the ICRC, International Committee of Red Cross in Kandahar, the local surgeons there used to remove the X-fixes and sell them off. So the question for us was, is it ethically appropriate for us to put the X-fixes knowing that they're going to be sold off? Or do we adhere to best practice and say, you know what, we still have to do our best for these patients. Yes, they're local civilians. Yes, for a large number of them, there were enemy combatants, but we should do our best. We have daily triage in the hospital in terms of rounds. We have a shortage of ITU beds, especially with COVID. Who do we decide is going to be discharged? Who gets the solitary appointment for a scan? Who gets the urgent emergency surgical slots? Yes, there are going to be clinical considerations, but do we allow at the end of a long day for our personal human factors or our ethical considerations to rule our emotions and decisions? Who do we take off life support? And this is something which we had to do on a weekly basis, because in Afghanistan, when we had less than 2 or 3 ITU beds, soldiers were not allowed to go out on patrol. So if the ITU was full, we had to sit down as a panel and decide, okay, we need to create 2 or 3 beds. So the focus used to be on the local civilians And we have to decide and play God as to which of them gets the opportunity to die. Now, what did we base that on? And it's a really, really difficult discussion, what we call euphemistically medical retirement, because a lot of it is based on human factors and lack of ethics. So what is the interplay between all of these? You know what human factors are, and they can be developed by training. It's something which can be approached day in and day out. People can be browbeaten until they recognize these particular problems. Ethics, as we said, are personal, normative, social, professional. It's a very difficult imbalance: military expenditure, poverty, health spending, gender inequality, landmine casualties affected by the disaster. This is Amnesty International. This is a photograph from the Vietnam War. What are the religious ethics of war? Is it Christian values, which have waged wars? Is it Islamic values, which are currently waging wars? What about the ethics of killing at a distance? Who does this operate? Who does one operate on first? This young man or this young child? On this grown-up man or this young child? On this baby with hydrocef or this patient? So where human factors, ethics, and triage come together with an appropriate touch, there is hope for all of us. And I'm talking about the last slide of the previous speaker, where he talked about the moral imperative for saving life. An example which we had in London, there were 5 victims for a 2-capacity ambulance, all of them P1s. There was a pregnant lady, there was a young immigrant youth, there was a policewoman, there was a bomber, and there was a child. Who would you select? And what do you base this on? As I said, all of them were P1. All of them required stat interventions. So ethics becomes very difficult. And of course, the law becomes very difficult, because the law would say that the bomber has to be saved come what may, because they can be brought to justice. And it's a very perverted way that we approach a lot of our mass casualties. And sorry to finish a bit earlier, but we have inherent biases and norms, and you can't discuss the ocean with a well frog. He's limited by the space. And you can't discuss ice with a summer insect. He's bound to a single season. So this is my final slide. But all I wanted to bring to note was that there are, all of us with trauma are involved with triage in one way or the other. We're involved with decision-making. All of us learn about human factors at some stage. All of us are aware of what ethical considerations are, but very few people try and address the impact of human factors and ethics on our prioritization in a multi-ethnic disaster with various forms of victims as to how we choose people. Thank you very much.
Ankar, this is a very different talk from your neurosurgical series.
I'm
Dr.
sorry,
Leventhal was struck by your slide in the airplane where it was 82 decibels or something like that, and was wanting to know how you might wish to approach controlling OR noise in a way that is effective and ethical. And as Avi says, because he's a thoracic surgeon, doesn't get you sent off to charm school.
Sorry, I guess each hospital has got its own rules. Each surgeon has got a different way they run their ORs. And there are certain people who love playing loud music and operating them. There are certain people who are very, very quiet. And this is where I say human factors plays a very important role, because unless you are a well-oiled team, there is very little scope for coordinated working.
Thank you. Your talk is so broad that my brain can barely even begin to comprehend all the issues you've raised. Fortunately, we have our president, Mallory Williams, here, who's much better at big picture stuff.
Yeah, listen, I love the quote. You can't discuss the ocean with a whale frog. He's limited by the space he lives in. You can't discuss ice with a summer insect. He's bound to a single season. And what strikes me the most as an operating high volume surgeon is that we're in an environment with different levels of breadth of education. So when we enter into these conversations, we have real restrictions that go unacknowledged, okay? And so the reasons and the rationale by which we come up with answers or quote unquote solutions are often very bound by the participants in the discussions. Not to mention there's really only one element within the discussion that's responsible for the clinical outcome, that's the surgeon. And so that is a limitation. I want you just to discuss how do we, within the confines of those limitations, begin to widen our discussions. Do we absolutely know that leveling hierarchy or non-dictatorial leadership produces better outcomes for our clinical patients in stressed environments?
So I personally feel, just like the previous talker, that protocols often, or flowcharts often, ensure that certain decision-making is streamlined and taken away from individual biases. However, the actual enactment of processes, of procedures, of your decision-making when everything comes to a similar level is so individualized that the only way you can do this is by regular, I would use the word practice. And the reason I'm saying this is, in the military, every time deployed, we used to ensure that we had practice runs for 1 or 2 weeks with the same team that you're going to be working with, using ethical scenarios, so that when things came to the crux, we knew what we were going to be doing. We knew that we were not going to be limited by hierarchical styles. We knew that we were going to be working to a certain set of ethics. And it is easier in the military where people listen. I have found it very challenging on humanitarian missions, because I've done about 44 of these, and where local personalities play a very important part. So the answer is, I genuinely don't know, but all we can do is try and practice for scenarios which are going to throw up the irrational or the impossible. I know it sounds like an oxymoron.
But you know, in military scenarios, correct me if I'm wrong, the military and its medical branch is there primarily to treat the soldiers, right? So if you have any additional time and any additional resources, you can help civilians. But if a military is in a conflict, it would seem to me that with very few exceptions, the main job description of the people that are there, not the job description that they may take upon themselves, but the defined job description by those that are sending them, is to take care of their forces first. That's before the bomber and that's before the civilians.
No, You couldn't be further away from the reality on the ground. Because we are governed by the Geneva Conventions.
Thank you.
We basically, it's all comers. We recognize that the people we fight with are enemy combatants of war. We recognize that the people who are getting injured, who are civilians, are our responsibility because we have caused the collateral damage. So there have genuinely been multiple times when US and UK soldiers have waited their turn, although they may be P2 or P3, ahead of an Afghan P1 or a Chechen P2.
But if they're all P1s, then what?
Then you decide whether it's the airway that comes first or the breathe. We literally go on a physiological anatomic basis. I know it sounds absurd, but I've had 4 tours in Afghanistan, and not once have we ever said, hey, you know what, we should be treating this guy because he's our own ahead of somebody else who's less serious. Oh, sorry, ahead of somebody else who's more serious.
Dr. Pandya, Dr. Kelly has a question which I think follows on to Avi's question fairly nicely. Ed?
Well, I'd like to comment on the what I'd call the utilitarian framework of the discussion of ethics that you've led us on, which I think is very informative and leads to a lot of good examination of one's own motives. But a lot of the greatest good for the greatest number carries with it some inherent inconsistencies. Who decides what the greatest good is? And is the number of the in-group better than the number of the out-group? Or what about the number of people that you haven't seen yet? You know, the old veil of ignorance where you say, should we conserve 4 or 5 external fixators for the next round of bombing that's certain to come in a 48-hour period? So those are things I think also help to shape the response in many ways. And actually, I'd like to ask to give us a little bit more information about the example of the external fixators. Are those being sold off in the further echelons to fund more care for people in those communities? Are they being sold for profit? Are they being used in lieu of other advanced technological treatments that the people in that area just don't have available to them? And if so, what's the ethical framework of not allowing them to have access to those fixators if it's a resource that helps the people in that community?
So number one, they were being sold off purely for money. There was no other consideration. And we found this out when, according to NATO, the doctrine in a military operating base, you were allowed to hold local civilians for only a 4 or 5 day period, because then you had to create space for the soldiers and the new onslaught of patients. So someone made a fact-finding visit and went to the ICRC hospital in Kandahar and found that these guys, the minute they came in, the X-fixes were being taken off. They were just being put in large plaster of Paris casts. A few of them had almost immediate osteomyelitis. A few of them landed up with amputations very, very rapidly. Our problem was that ethically and in terms of best practice of medicine, with the gunshot wounds and the blasts that we saw, there was no other way of stabilizing an extremity apart from putting an X-fix. So we had to continue doing that and hope that somewhere down the line, someone saw reason, or that patient was slightly better connected locally and they allowed them to keep their external fixator. And I agree with your comments that this sounds like a very utilitarian approach, but it is such an open-ended discussion, especially with the way the world has been over the last 4 or 5 years with what we call terrorist incidents in multi-ethnic areas.
thank you for your expanded explanation. That was very useful.
This is it was an excellent series of answers, and
Correct
as
me if I'm
Unker frequently manages to raise a whole slew of questions. Is someone trying to ask one more question?
Yeah, from what I understand about the Geneva Convention, it's very conflicted whether it applies to terrorists or to, non-standard enemy combatants. There are very wide diversity of legal views on that.
I agree with you. The legal view taken by the United Nations mandate, which got the Western nations into Afghanistan, was we are creating the war, of course, in response to somebody else. Any person who engages against us is going to be an enemy combatant of war. Any civilian who gets injured is going to be a collateral damage because of our actions. So the buck stops with us, and we do what is required. There was absolutely no ambiguity on this. So I completely agree that people can interpret it the way they want, but before you go into an area of operations for a conflict, there are certain rules which are laid down and certain guidelines which are laid down. So just like your response to fire or whatever, but this is the way it was. And I think it's the appropriate ethical thing to do, that if you're going to go and cause damage, we make sure we pick up the consequences of whatever damage we do. Why should children suffer because Bush and Blair or somebody equally incompetent decides to go and bomb another nation?
Speaking on behalf of the marginally competent, I regret that we're going to have to stop this remarkable discussion. If everyone were here in person, we could continue it on the chairlifts. Ankur, thank you very much. Of course, you'll be here next year in person, and we'll be able to dig in deeper. Our next speaker returns to the thoracolumbar spine, and we have Dr. Sonny Gill, who has an extensive career in this sort of thing, having set up the Stedman operation in South Carolina, and now a dedicated spine surgery facility in the same town. He has, in addition, an extensive interest in sports work, and he's going to be talking, just as Dr. Munz did, on thoracolumbar spine injuries. Sonny?
Thanks so much for your guidance here and allowing me to be a part of the meeting here. It's humbling to follow that talk, Dr. Pandya. That was very, very interesting. So I'm going to try not to be too repetitive. I think I've had a lot of colleagues who have gone through the system at Landstuhl, and they see a predominant number of the war type injuries, which I assume is a hot topic for this meeting. And the reality is, this is one of the most common injuries we're going to see. And it can happen with anything. Since we're in a ski hill, obviously there's tons of evidence of that, where we're going to be taking care of people that seem like they have very innocuous type of injuries. When you look at something like this is just a very simple missed landing where he sticks the landing, boom, and it doesn't end up well for him. He's one of our World Cup athletes about a decade ago, and it can be something even as silly as just maybe not, but just trying to make sure everybody's still awake here. But one of my charges always, and I say this full bore, is that we always have to take into account head and neck injuries, because they go hand in hand, because you can really have distracting injuries, and that guy just knocked out cold. So don't forget to scan the entire axial skeleton. And that's the one thing that I would probably hammer home. And that's something I talk to our trauma surgeons a lot about, is did we get an imaging of the head, cervical, thoracic, lumbar spine? Because we got to make sure that there are no concurrent injuries going on. And I know that you've been beaten to death about missed injuries, but that is one of the things that we worry about the most. So, just to kind of reiterate a little bit what was said earlier, the thoracolumbar junction really is the main area where we look at it. And it's because it's the transition. Think about it. The thoracic spine has a stable rib cage. It's a cage. It attaches to the sternum. It's very stiff. It's very rigid. Really doesn't have much rotation based on the facet joints. and also the fourth column, which I talk about being the sternum, not just the anterior, middle, and posterior columns. So when we think about why that happens, it makes sense that if you're going from a very rigid spine to a mobile spine like the lumbar spine, that's where the energy is going to dissipate. We've heard a lot about the non-operative criteria, and obviously things play an account. What time of day is it? Do you have the staff? Degree of neurologic compromise? That should be the overarching thing that really, really hammers home why and what you're going to do. And then, of course, stability, deformity, all those things we'll talk about a little bit, which will push my hand more towards a surgical treatment arm. Most people at this point have heard of this model. The Denis 3-column model is anterior, middle, posterior. Obviously, the middle is a hot button because that, when it retropulses into the canal, creates that compromise of the neurologic elements, creates that neurologic deficit. It really harkens us then to look into that a little further and say, do we need to do something here? Is it something that we have to go one step further, and we can't just say, all right, treat and brace? So that's where I kind of say to myself, are there better guidelines? Can we give us a classification system where we can actually quantify this? We can talk to our colleagues and say, all right, so take an example of what this has come to about, the thoracolumbar injury classification score. It's a great system. It's not hard to use. You can put it in your, phone and just take a picture of that. But think about how common this is, right? So I want you to focus on 4, which is the indeterminate, and then 5, which is most likely surgical. So let's say they have a burst fracture. Their posterior ligamentous complex, meaning their supraspinous, interspinous ligament. Maybe, maybe not. Maybe they have a little signal in the MRI. It's pretty common. So now you're already at 4. Right. And every time, that's where I sit and I say to myself, is there a neurologic injury? And if that is, that most likely is going to push me into a surgical arena. So we've got these things to think about. We've got the Denis classification, we've got TLIX, we've got fracture stability, but neurologic injury, really hammer that home and really think about, do we have to look further into what we need to do? Other common classifications, and I put these out there because I think it's helpful when you're trying to relay information, for example, from a trauma team to a spine team, trauma team to a neuro team, whatever it may be, whether it's compression, burst. And then you've got the really bad actors like the fracture dislocations. You'll see where the spine actually spins and rotates off itself. And these are neurologically devastated for the most part. These are paraplegics, if not worse. And these are going to be significant injuries, and they're probably going to have some bowel injury too. Now, the one thing that's interesting that I always pause on is seatbelt type injuries. Those are the ones where they actually unhinge on the spine. And it's that chance fracture, which you may have heard about. But the problem with that is those often have hollow viscous injuries, which goes back to your situation. So that's where I always have to say, hey, has the trauma team cleared their belly? And I think that's where we have to, as spine surgeons, back off for a second and make sure you guys do your thing. So there's kind of the guidelines of what we're thinking about. Obviously, C, there's that rotational injury. It's a horrible injury. That's a devastating injury. The compression burst, that's an everyday garden variety, what we see all the time. And then B is that unhinging, where that pivot point is well anterior to the spine. And that's why it's a little different. So when we think about moment of inertia, when the moment of inertia is closer to the spine, you're going to have a little bit more of a compression burst component. The burst obviously is when the middle column fails, that Denis 3-column model. And then the seatbelt dislocation is when that anterior force, that moment of inertia, is well anterior to the spine, such as at the abdominal surface, and it unhinges and comes back. And it can be pretty innocuous looking on the x-rays, but you just don't see the dynamics of the injury. One of the opportunities I've had in my life was to work with the Auto Safety Association when I was at University of Virginia. And they showed this image of a cadaver in a car as it gets T-boned. And it's just humbling when you look at the x-rays of the injury and then you see what the energy mechanism was when the actual MVA occurred. It's amazing. So we always have to remember that the energy that dissipated through the body is most likely a lot more than what we're seeing on the x-ray. So compression fractures, that's, we've talked about that a little bit. I won't bore you with that. That's going to be most likely neurologically safe, intact, and we're going to let that be as a non-operative component. And then we start working ourselves up the chain. This is an interesting compression fracture. This is a much higher injury. And you can see the schematic on the left where you can see that little deviation where there's a sagittal split and the entire anterior body is basically coronally split away. That inherently can be a very unstable injury. It doesn't look horrible. The middle column is intact theoretically, and the neurologic status may be intact, but that's one where I have to say to myself, we need to get upright x-rays. We need to make sure they're stable and that we're not missing something. And that's, I think, when it's very, very helpful to consult the spine team early, because they may not have a severe abdominal injury, but they may really have an unstable spine that can create worse neurologic outcomes in the future. All right, now moving on to burst fractures. Everybody's seen these, and this is a significant compromise. The burst fracture goes into the canal, invades it, so to speak, and it really can create durotomies, nerve root injuries. It can create extrusion of the disc in the canal. It can be a troublesome mechanism. Interestingly enough, there's been a huge momentum. And one of the fellows out of the University of Florida has really published strongly in treating these non-operatively, even with subtle neurologic deficits. But let's be honest, when you're testing the hip flexors in a quadricep, you're testing the hip flexors in the quadricep motor, and they have pain, they may give way a little bit. So sometimes it's very hard to determine, is that pain inhibition? Is that true neurologic problems? So we have to say to ourselves, what's the best way to treat this? And there's some art to it, but I do think that there is a good body of evidence that shows that that burst fracture will resorb. If you remember Wolff's law, if the bone isn't under compression, it'll resorb and that canal will come through. And they've shown really nice serial CTs at 1 to 5 years where that canal recanalizes. And it's amazing how that becomes another clean area where the spine actually can have a full neurologic recovery. And here it is kind of on a CT, and we think about it, obviously very teleologically, where we say, well, that mechanism of that canal intrudes into it. I always want to point out that there's some evidence where we can see that, is there a bony fragment that can cause a durotomy? Do we have a sagittal split in the lamina? And those are the things that make me worry a little bit, because then I say to myself, there could be a durotomy. And this is a really good example of that. You can see how the lamina is split away from the sponge process. And most of the time that dura is going to extrude through there. And it's going to have a neurologic tear in the thecal lining. And we're going to have to repair that, because you just can't leave that alone. You can also see here subtly that the pedicles have widened when you're looking at an AP x-ray. And you say to yourself, wait a minute, look at the pedicles, how they have a very standard architecture where as you go down the lumbar spine, it just very subtly widens, but this is significant interpedicular widening. So little clues where we say to ourselves, this could be a better or bigger mechanism of injury. The seatbelt type injuries, as we talked about earlier, remember, don't be misled by the fact that, wow, it doesn't look horrible in x-ray. That mechanism of action could have been horrific, especially in a pediatric patient where it may be a ligamentous injury, because the ligaments may be stronger than the bone and it can rip away at that annular bone junction. So always think about, boy, am I missing something here, especially if they're in significant extremis and they're just not neurologically following what you think would be a radiographic model of where they should be. And there it is, a seatbelt injury. That one's a little cloudy, but you can see how it cracks right through the bony arch. CT scan obviously is going to be very helpful. Going to the horrific ones, the type C, C1, C2, C3. C2 and 3 are significant translation and rotation. Those are going to be very obvious that they're going to need help. They're going to need a reduction. They're going to possibly need an anterior posterior or even a posterior anterior posterior type injury. So those are ones when we look at the CT scan, you say, wait a minute, this is absolutely horrid. There's 2 axial cuts of 2 different vertebral bodies. And we say to ourselves, how can that possibly be? And then it makes more sense when you say to yourself, yeah, that is a rotational injury where they're overlapping and one on top of each other. And that's certainly a harbinger for further intervention. And don't forget, these are very high energy. These are ejections from a car. These are logging injuries where the log can actually almost transect the cord, and they can even dislocate the rib heads from the spine. It's amazing how much energy goes through the spine at this point. So always keep that in the back of your mind of what's the energy of the injury, and that's where I kind of start thinking about, Is it a ground level fall? Was it an ejection from MVA? And there's whole breadth of diversity in between those two. So really start kind of thinking through that, because that's where the energy dissipates, is in the body. So the key here, right? So we talked about stability, neurologic deficits. We talked about mechanism, but we want to be able to maintain relationships of the spine and the neurologic structures when they're upright, and not create any further deformity, pain, or neurologic compromise. And that's the definition. And that was White and Punjabi in their seminal work that they published that. Sorry for the background noise. And those were the initial talking points that we said, all right, how do we determine whether something is quote unquote stable versus unstable? Obviously, we tried to make it simpler. We said, oh, it's 50% height loss, canal encroachment. These may not be true. They may not be totally exact, but that's some rules of thumb that we used initially. I will say one thing that has held on very steadfastly is the kyphosis. The more kyphosis you have, especially when you change from a supine to an upright x-ray, you're going to have more evidence of a thoracolumbar unstable fracture, because the ligamentous injury, the discal injury, you're going to have probably neurologic compromise where they may have more radiating pain. So that's kind of the thought process of where I'm at when I say to myself, is this stable or not? So that's where then it trends towards my realm, where you say to yourself, all right, now we got to transport these people wherever it may be. This is in Zermatt, which Jamie probably knows very well. And as you know, in Zermatt, if you need bread or milk, they send a helicopter. So, and certainly here, when they have an injured athlete on the course, they're going to send a helicopter in, they're going to long line them over, they're going to put them in a papoose and send them out. It's a pretty amazing way that they transport athletes and injured skiers away from a mountain, because it's a glacier, and getting them down is 2 very long lift or gondola rides, if not 3. And this is the safest way to extract somebody, but the long line is not common, but I just think this is an interesting way to do it. So obviously we're going to talk about spinal precautions, log rolling, rotobed, all those things, kin air overlays, all those things to make sure we don't do anything worse, like give them D-cubes. DVT prophylaxis is so important. Don't forget about the H2 blockers. Steroids, you know, we've run the gamut. We can do a whole talk on that. And at this point, it's not recommended. The NASA's criteria shows it's more harmful than good. But I think the other things to think about are there other issues going on. Obviously, if they have a rotational injury and they're paraplegic, they could have autonomic dysreflexia. So you're going to have to take care of their hypertension, their diaphoresis, because they're going to have a parasympathetic sympathetic mismatch. So think about the urinary retention. Obviously, you're going to put a Foley in, so that will help that. Non-upper management, we've talked about that, you know, less than 30 degrees of kyphosis. Can we brace them? You know, remember, unfortunately, not everybody is a BMI of 25. You know, we don't live in Zermatt or the French Alps. You know, some people practice in South Carolina, Alabama, Oklahoma, and it really, you know, some people are not amenable to bracing because of the fact that the brace just can't hold that soft tissue envelope enough so that they don't completely go into kyphosis. So that's where I think about other opportunities for when we have to progress on to a surgical intervention. So then we kind of stratify. Is it emergent? Is there a progressive neurodeficit? Is it an irreducible dislocation? That's got to go right away. And then urgent. And urgent now, you know, if you look at older studies, you look at 87, less than 5 days was urgent. My God, we wouldn't call that urgent anymore. Urgent now, we're talking about less than 8 hours, less than 4 hours, less than 2 hours. But even if you talk to some of our colleagues at Shock Trauma who are spine trauma specialists, they'll say, if you landed in the trauma bay, it would still take 6 to 8 hours to get everything they needed to get everything set up. So the goal obviously is as fast as you can if they have a neurologic deficit. The one caveat is that if you're going to go anteriorly and they have a burst fracture, there's going to be a lot of blood loss. It bleeds like crazy. So there is a chance for equipoise where you say, do we need to hold because they're hemodynamically unstable? Is this something we can wait a minute and do it in an urgent, not emergent fashion to help them be safer? So surgical consideration. So you can see how when I think through this, there's so many things that are going through my head. Are we doing the right thing for the patient? Are we going to help them in the long run? Are we going to be able to maybe save them some roots? And I can't tell you how incredibly helpful that is. So when you think about quadriplegics, if you can save them C6 they can actually motor a wheelchair. They can extend their wrist. If they've got C7, they can transfer, they can use their tricep. So that same mentality goes to L1, L2, L3, where can we save them their quad? Can we save them their ankle? So we really have to think about those things because root level recovery is very important to a spine surgeon. All right, so obviously the burst fractures, we talked about it. If it's stable, no deficit, we're going to leave it. Good studies have shown that you can treat those non-operatively and people can go back to work in their respective lives. But there is a trend now with newer data to show that people recover faster and do better with operative intervention with these burst fractures that may be quote unquote benign, because we have ways to internally brace them now, where we can do percutaneous screws and brace them with a long or short construct, and we can take that out at a later area or later arena when they have already healed that, so they don't have to brace and we can get them upright, especially if they're a polytrauma. If they have a chest tube, or they have a abdominal injury, or they have a femur fracture, we want to brace them internally with pedicle screws, and that way we don't have to put a big bulky brace on which they won't be able to mobilize very well and be at more risk for complications like DVTs and D-cubes. So short segment, long segment, all those things we think about. We look at bone density. I'm really a big fan of thinking about, is this an osteopenic or, if God forbid, an osteoporotic fracture? Because, you know, people in their 70s get ejected from cars too, and that can be a big issue. And when we think about the burst fracture that we saw earlier, where it's retropulse, what do I need to do to make this a neurologic improvement? That's what I'm always thinking. If you look here, this telltale sign, the sagittal split in the lamina, I know that's a dural injury. That is where the nerve is entrapped. And I'm going to have to do something posteriorly for sure. So I may even think about going anteriorly first to stabilize it, and then posteriorly coming back on that with a pedicle screw fixation to hold that solid, do a decompression, repair the thecal sac, and then put those nerve roots back into that sac before we repair the sac with a 6-O-proline, 5-O-proline. We may even have to drain it with a lumbar drain if it's a significant injury to protect our repair. So all these things come through our mind. You know, short segment fixation has been very popular. Obviously, we worry about fracture of the pedicle screw or compromise where it pulls out. So we have to think about bone density. We have to think about overall morphology, BMI, element of the injury. Is it a high energy injury where we have to go longer? Do we need to go 3 above, 2 below? So all those things we think about and want to know what's the next best opportunity. Flexion distraction, that seatbelt injury, you know, if it's a bony chance, we can brace it. Sometimes it's just a little bit more in the realm of, can we get this person mobilized quicker? And that's the thing I think about, especially in a polytrauma situation. If you're dealing with a polytrauma patient, you're going to lean more towards intervention versus leaving that alone. And it can be something very simple where you're just clamping that back on together, just a hook rod construct. So there's simple ways to do this where you don't have to do a lot of soft tissue compromise. And I will tell you, with our minimally invasive screw systems now, we can do all these percutaneous screws. We can do screws 5 and 6 on each side and put a percutaneous rod where we slide it with a passer and have less than 50 cc's of blood loss. So it really is a huge advantage for where we're at now. Remember the distraction extension injury, it's really not an anterior column. It's more kind of an unhinging. So these are more in the metabolic disease patients, the DISH, the ankylosing spondylitis. It's very common. Usually they'll say that they were kyphotic to start with, and they may do something very simple like fall backwards in a chair, or they may have a very minor car accident. The most important thing is don't miss this, because the plane of the injury is in the axial cut of the CT scan. So look at those coronals, look at those sagittals, make sure you're not looking at a spine that initially was kyphotic and now is hyperextended and you say, oh, that looks pretty good. So really make sure that you're intervening appropriately for those. So we're going back to the fracture dislocation. We know that's going to have a neurologic deficit. You're going to have to reduce it. You're going to have to reconstruct that tension band posteriorly. You're going to have to safely rebuild the spine anteriorly. And like I said, these are going to be combined procedures. They may be posteriorly first to reduce it, get it in line again, repair the thecal elements, go from the front to reconstruct that absolutely hammered vertebral body, You may even have to go posterior, anterior, posterior to help with the reduction. It's just such a quandary sometimes. And you can see how that spine is completely here's the vertebral body completely dislodged. And that's a C2 type injury where it's not significant rotation, but immense amounts of rotation. We're going to do long constructs on these. We're not going to be shy on these. And we're certainly going to make sure that we reconstruct them anteriorly, where you can see that even in this situation where you can see a fractional dislocation with 2 cuts of the vertebral body, we have multiple layers where we say to ourselves, gosh, we really need to stabilize this. And they may not be amenable to an anterior operation initially. The first thing you might say to yourself is, I got to reduce this. I got to see if I can improve them neurologically, because you can't sit on that. So posterior may be the day 1. And then when they're stabilized, day 2, day 3, day 4, then you can go anteriorly do your more definitive reconstruction. So don't forget about the acute neurologic injury with these too. And that really is the way to think about these. Of course, that burst fracture, that incomplete deficit, you can see once again that very nice MRI where you can see that sagittal split in the lamina and that nerve root being entrapped there. Is there a difference between anterior and posterior? A lot of it has to do with neurologic deficit. A lot of it has to do with your familiarity. Do you have a team that can do a thoracotomy or take down the diaphragm to get you there? Or can you do everything from the back where you can actually go to the front from the back? The so-called costovertebral angle approach, where you actually take down some of the rib head, you slide down the lateral side of the vertebral body after taking down that transverse process. And you can really do a lot of work to the front from the back. So there's lots of different approaches. Posterior is, it's tried and true. Spine surgeons know it. They know how to repair the dura. They know how to reduce it. So that really is something where you say, what's the comfort? What's the familiarity? What's the neurologic status? Obviously, the posterior approach, we're going to do that more in the lower elements of the spine because the vessels are there. Then we can certainly connect the spine back to the ilium or the pelvis, where such as a jumper's injury. You can even see the coils here with the big vascular injuries. So there's a lot of reasons why we may have to avoid going from the front. The advantage is obviously is direct reconstruction. You're going to redo that with a cage and be able to really put a nice robust support anteriorly where you can redo that entire segment and make sure they're stable. So we have a lot of things in our armamentarium: stackable cages, expandable cages. We can even reduce it with a laminar spreader, put in the femoral. We can even use, if you're somewhere where you don't have these beautiful instruments, you can use a femoral allograft. You can put that in there and then you can plate it. You can use even simple things that I've seen where you can use K-wires with polymethyl methacrylate, which is cement. So you just use whatever you have. And even though these things are all very elegant, like a vertebral body replacement, don't feel like you don't have the initial ways of doing this. This used to be a tuberculosis operation. And they did what they could. They even would take big chunks of iliac crest from the patient and put that in there. So think about what's available. It doesn't all have to be beautiful instrumentation where it's simple. And I'm showing some simple ones where it's not pedicle screws at every level. It's just hooks and rods. And that may be what's available. So just think the neurologic injury, the stability, and what the way to reconstruct it is. Do we have to go anterior, posterior, or both? And do we have to reduce it? So those are our goals: maximize neurologic recovery, maintain an anatomic reduction so that they can transfer, they can move, they're stable for rehab. And that's what the goal is, to get them as mobile as possible, because in the long run, that's what's going to make the difference. So maximize their level of independence. These are humbling injuries, and the subsequent neurologic deficit can be long-term from a psychological and from also a mobility standpoint. So we'll finish it real quick on a case example. Sorry, I'm just right to the moment here. L2 fracture. And you can see how the spine, the cranial aspect doesn't match up with the caudal aspect. And you can see a significant rotational deformity with a crush injury of L2. L2-3 is rotated off. We look at the CT scan and we say, yep, we know what that is. There's 2 different vertebral bodies and a complete obliteration of the vertebral body. So we know we're going to have to reduce this. And this is going to be a posterior anterior type procedure. And we're going to reconstruct that for stable transfers. And unfortunately, these are neurologically devastated most of the time, including bowel and bladder. And the goal is to be able to have them learn how to self-cath and be able to toilet. Thank you very much for allowing me to be a part of this society. And I've learned quite a bit this morning also. So hopefully we can see each other in person next year and find the snow for each other. Thank you so much, guys.
Clemson. We have time for one question before Dr. Barbara Perry and Dr. Marjorie Perry talk to us about their relationship with the society and architecture. Dr.
One more time.
Williams? Oh, go ahead.
Wonderful, wonderful presentation. I enjoyed it, the elegance of it, everything. When working with the trauma surgeons, particularly with the chance fracture, talk to me about your approach when there is a hollow viscous violation, particularly colon. And let me just say, you know, I think the difficulty for me has been penetrating trauma when I've operated, and there's been colonic injuries with penetrating fractures. Luckily for me, they've been stable, but you can tell me your perspective as an orthopedic surgeon.
Absolutely. That's a nightmare. So anytime we have a hollow viscous injury, obviously they're not going to have a bowel prep on the way to their trauma. So the abdomen's going to be contaminated. Most of the time you guys are doing a diverting ostomy, and that it tips my hand. That's when I say to myself, that's a posterior operation until you guys allow me to say, hey, if you really need to go anteriorly, okay, but stick with the posterior. So that's where I let my trauma surgeon guide me. Now I will tell you, with a lot of these newer techniques, we can go to the front from the back. I can slide a cage in. I might have to sacrifice a root like a L1 root or a T12 root, and that's perfectly okay because I get a sensory deficit. But I can manipulate that cage with these expandable cage and then increase the height of it as I slip that in there to reconstruct the vertebral body. So we do have our ways. It's tricky, but you just have to have the skill set, if you will.
Thank you, Dr. Gill. Dr. Kelly, a quick one.
You had mentioned in your discussion that there is a role for a staged approach to these complex fractures, where getting a control of the injury and getting some stability that enables you to work with the patient a little bit more. Typically, if you are going to do a follow-up operation, what's your window of timing for that? And what are the goals of the second intervention?
That's a great question. So if you're thinking of a staged injury or a staged operation, that's going to be a rotational type C, all right? Or even translation. So my first goal on the night of the injury, and remember, these can't wait. These are emergent. These go, right? And obviously, if you say to me, hey, they're bleeding out from a iliac artery or iliac vein rupture, then yeah. But once you guys say, hey, they're hemodynamically at best as they can be, lactic acid, we're not going to look at. I need to reduce that spine. I'm going to do a wide decompression, probably take 3-4 lamina off. And I'm going to look at the nerve roots. I'm going to look at the thecal sac. No question that thecal sac is going to have some compromise, right? And I'm going to instrument long. I'm going to go 3. Let's say it's a T12L1 fracture dislocation, very common, right? I'm going to do laminectomies T11, 12, L1, maybe even L2, and I'm going to go from T9, 10, 11, and then I'm going to skip 12 because the pedicles are probably blown. And I might have a short screw at L1 and go L1, L2, L3, and maybe even 4, depending. That's it for the night. We close up, we put drains in. The soft tissue injury may be bad. I may have a plastic surgeon come in there and say, hey, I need to rotate the flaps of rector spinae muscle. It's amazing. Our plastics and reconstructive surgeons, they can flip those on fast like a fish and put that in the muscle belly, or put the muscle belly into the wound so that they create a nice healing bed. And then we wait. At this point, we've done what we need to do to stabilize. Now, the next goal is to be able to get them to mobilize. And that's where we have to say to ourselves, we can't just depend on a long construct. That'll fail. It's like a paperclip. Eventually, it's just going to snap. So I might have to reconstruct it anteriorly.
And whatever, we expected a really great talk, and we got it. And thank you very much.
Sorry, I ran over a little bit there.
Professor Marjorie Perry Callahan is going to be introduced by Barbara Perry, her sister. The ongoing Perry contribution to this group continues. And I am really curious what we're about to learn. Doctors Perry, are you ready to go?
Yes, I am. Thank you very much. I'm especially honored and pleased to introduce my sister, Marjorie Perry Callahan, Professor of Architecture and former Associate Dean at the University of Oklahoma. to give a presentation on public trauma, the architect's role as healer. It's the least I can do after she listened to my first academic meeting presentation to the RMTS many years ago, at least a dozen times. Before I formally introduce her, I would like to read the first stanza of a poem that I think captures the essence of her presentation. "And Death Shall Have No Dominion" by Welsh poet Dylan Thomas. We Parrys are particularly fond of the Welsh, as well. Parry is a Welsh name stemming from Ap Harry, meaning son of Harry, the surname given to Henry VIII when he annexed Wales to England. "And death shall have no dominion, dead man naked they shall be one, with the man in the wind and the west moon, when their bones are picked clean and the clean bones gone. They shall have stars at elbow and foot, though they go mad they shall be sane, though they sink through the sea they shall rise again. Though lovers be lost, love shall not, and death shall have no dominion." Professor Callahan received a Bachelor of Arts degree in Urban Economics and Art from Mills College in San Francisco, a Bachelor of Architecture from the University of Oklahoma in Norman, a Master's of Science from the University of Massachusetts Amherst, and a fellowship grant from the Rhode Island School of Design in Providence, where one of her three, all very talented daughters, now teaches. She has received numerous excellence in teaching awards, including from the state and OU provost for her work in graduate liaison, which she has received international recognition from the American Institute of Architects, from whom she was selected as one of 5 scholars from across the country, for Faculty Alpha Omega Leadership, and for the Mayor's Community Service Award. Instituted by Secretary of State John Kerry, she was invited to participate in 5 diplomacy labs by the Washington, D.C. Federal State Department to develop global public-private partnerships in entrepreneurial architectural mindsets in developing countries, now involving the International Red Cross in Geneva, Switzerland. She was awarded funding by the Institute for Human Flourishing to encourage the practice of lifelong virtues in coursework, and to my particular delight, now incorporates poetry into her classes. She currently is working on a project to enhance architectural design in women's prisons to help reduce the recidivism rate there. All activities reflective of her focus on community and global engagement. I have been encouraged by her description of architecture moving towards the simplistic and natural designs versus those of high technology, especially since my own work encompasses returning to more simplistic and natural sleep and light interventions to treat depression. She's taught me much about the role of architecture in expressing beauty, helping to transform grief and chaos into solace and peace. Although I study mood disorders, it never occurred to me how much architects consider mood in their designs. More specifically, I was very moved by her presentation on the moral response to beauty to a C.S. Lewis conference in Amherst, Massachusetts, on beauty in the public square. Inspired in part by the character of Frank, a London cab driver in Lewis's Chronicles of Narnia, the magician's nephew, who on viewing the magnificent creation of Narnia states, "Glory be, if I'd seen this before, I'd have been a better man all of my life." A sentiment echoed by her 23-year-old daughter, who on viewing New Zealand's beautiful Lake Tekapo said, "If the jihad could see this, I bet they'd be better people." She also was very influential in changing my thinking after expressing disappointment at seeing the Lady Di Memorial Fountain in Hyde Park, London, which used to be the Perry family ancestral land, but being poor farmers, they had to sell it to the crown. Compared with the nearby upright Prince Albert Memorial and the structured Italian gardens, I thought the wobbly circle was disrespectful to her. My sister pointed out that that function is beauty, and that this fountain was functional and beautiful in its serving as a play pool for children and reflected her feminine, undulating influence in the royal family, and her interweaving herself into the hearts of the common people, becoming, as Tony Blair described, the people's princess. As her lover of the old Tate Britain with all the Turner paintings, she also helped me to appreciate the Tate Modern Gallery, pointing out it was an old factory put to good use. I'll turn it over to her to influence your thinking about the role of architects as healers after public trauma. Take it away, Margie.
Thank you very much. How can you go after your sister takes you to such a high level? I hope I can maintain that. Okay, Can you hear me?
Yes.
Okay, I'm going to begin. I first want to start this presentation again, being honored to speak at the Rocky Mountain. As Barb mentioned, I grew up being part of my mom and dad's work, and I've always had the highest regard and never saw that I could speak at it as well. I would like to mention that this work, I have a graduate assistant in regional and city planning at OU, and helped me put this together. Yes. So tools of an architect. We can set the stage, put a mood in the space. We can detail physical space to make it really placemaking. We can frame views and put in edges, and we can put it in context to make it relevant. You are seeing these sort of dark sketches. My daughter, who came home from the Rhode Island School of Design, which my husband and I were a little bit concerned about because of the price of the private school, and showed us these, and we were a little skeptical, but she said to us, I'm not there yet, but I'm learning to set the mood, the atmosphere. It's not about the pieces, it's about creating the mood. And so I want to say that at memorials for trauma or grief, an architect here, the Oklahoma City Bombing Memorial in my hometown here in Oklahoma City, created in an urban, busy city, silence and peacefulness. And in New York City, the 9/11 Memorial, the architects created the feeling of emptiness as a mood. And as Barb mentioned, the architects, landscape architects for Princess Di, set the stage of play, life, activity, definitely beautifully. Architects can detail, impact placemaking. We can add light and shadow to be impactful. So here in Uruguay, in the daytime, the light fills up in the bowl by the sun, but in the evening it changes and the light comes in and the bowl in the darkness stays dark. Here in Oklahoma City, again, the lights on all the chairs of those that were lost in the bombing present a sense of hope and consolation when at night it is so gloomy, and some of the chairs represent the young children. We can select materials to bring in texture so that people that visit can feel, can touch, can smell. So there's mindfulness. So for instance, at the Vietnam Memorial in Washington, DC, the wall is reflective to make a connection between the past and the present. So the visitors, even though get discouraged and saddened by all the names on these walls, can reflect and see that they're still alive, that they have a present. In New York City, the texture of the pavement along keeps you mindful and doesn't let you drift away. We can add color. Let's go back to the psychology of color and how impactful that can be in itself. Green nurtures, lusciousness of the promised land. Red is warm and positive, and action to be taken. And black, of course, is the absence of color. And so often memorials, especially here in Washington, DC, nurture. They are surrounded by the point of grief and trauma and demonstrate that there is still hope. In San Diego, there is a concept to inspire. And so the architect red roses, of roses, hopefulness. We can add as architects pattern and composition when the pattern there adds richness to the palette and deepening. As for even a pattern sound, this exhibit was very pattern oriented but in each of the vestibules, a different sound came out by mourners. We can frame views. In Africa, a beloved leader died, and this is the memorial to him. And when you get to the memorial, it zooms you up into the air for you to sense, oh, yes, you still have a leader caring about you and looking care for you. In Washington, D.C., you walk up the stairs to see the Lincoln Memorial, and you're so inspired by Lincoln. But then as you turn, the architect has also framed the view to inspire you to consider going on, going forth, and being helpful to the political world. So how do architects respond to trauma in public space? I would have to say it's beyond aesthetics. We know it's an emotional experience we can develop and design. We can add these raw materials. We can sense a sense of place, but we also can induce calmness, safety, empowerment, and well-being to those traumatized. So I just want to hit some precedences in trauma in public spaces. Lynching in America, the hanging, it created terror and trauma. The Holocaust in Europe, we know, created terror and trauma, even still today. Political prosecution, you know, it's worldwide, but I just brought in Czechoslovakia. It created terror and trauma. So in the National Memorial for Peace and Justice in Alabama, it's dedicated to victims of racial terror. Processing grief, we frame the view, the memorial ground drops, and then as you move further in, it deepens. And of course, they're symbolic, creating the columns that demonstrate the lynching. The materials at the National Memorial for Peace and Justice are made of a Corten steel, which is a group of steel alloys developed to eliminate the need for painting. They take care of themselves over time. They learn to be resistant and strong. And inside, the 800 steel hanging columns represent the countries where all the lynching transpired. Now we move to the Holocaust. You know, definitely murdered Jews in Europe. This is a famous architect, the United States architect designing in the heart of Berlin. Again, I'm going to hit the materiality, the viewports, the symbolism, the texture, the color. So of course, horrific trauma. And to aim for these memorial sites to speak the unimaginable. Some individual peoples can't speak it, but the architect can help the public speak it. And so the execution sites were out of the country, but they brought it into the center of Berlin, really make it more impactful to the public at large. The materiality is 2,700 lab slabs with different heights, from, you know, representing all the different types of people. The viewports are up and down. And then, of course, the symbolism of tombstones. Again, the architect was trying to impact the importance of individual uniqueness and sameness. And even the texture is cobblestone and not smooth. And so as a spectator going in there, you experience that you've got to pay attention and how disorienting it could be. In the basement, the relevancy of making the individual, again, relevant. And then political prosecution, another example. You know, victims are remembered both individually and just or as a source of a public viewing of just sort of the overall idea. A descending stairs with naked men losing as they go up the steps more parts of their bodies. And at the end, there's only a ragged pair of feet left. But as you descend the stairs, the individual victims are honored. So trauma, you know, I'm an outside to the medical profession. So I just, when looking at this, the emotional response to a terrible event, an emotional response to an event or an experience that's deeply distressing or disturbing. So how do architects take all this individually different responses to this? We move into it as trying to take it as a transition from a state of shock and dismay to a new enduring reality that is helpful and supportive. So I'm just going to give you some more sort of helpful ideas. The tomb here up in Portugal, the architect added a special room in the middle of all these crematoriums to allow a participant in the sadness to sit here and then look out into the beautiful surrounding landscapes beyond and realize that the transition is that it's slow, but you move on out and have hope. So, you know, we know the 5 stages of grief, and we know that individuals don't take these on the same, but how is architecture in a public realm, can we help with this? And so many believe that if you face the loss, the trauma, and reflect and gather the pieces into a whole, then the community in one can move out in stronger, more helpful way. So in Oklahoma City bombing, you leave the urban traffic streets, you move through the gates of time, and you are allowed to enter the space and meander through it is any way you want. And then you leave on the west side, which is marked 903. And though it marks the time after the explosion when rescuers arrived and the recovery began, it also is symbolic for this audience or the spectator that comes to visit. So how are architects also relevant to place, to culture, and to event? As my sister mentioned, you know, who is the client as the architect designs these places of trauma or recovery of trauma or grief in the public setting? It's also hard for the client to take the client. In the left, Prince Albert Memorial, of course, was initiated by the client, his beautiful queen wife. And she put him on a hierarchy. And so that's what the architect did. But if you read about Prince Albert, you know he's such a color researched, lovely individual. On the right, who was the client, the landscape architect refused to just accept it from the royal family, but heard the community and the public and designed it much more appropriate to the wishes of that client. But also the ability of where you put these demands attention. So of course in Hyde Park, as you can see down in the lower, is very organic and warm. And so it was the appropriate place to put an organic, feminine, gentle site for Princess Di. But on the left, you know, when Maya was asked to design in the Washington, D.C. Memorial, we know that it's linear. She had to design with the idea of being strong, masculine and linear. I want to say that a client, whether it's public or you know, the city or whoever, the ability to decide where the site is also very impactful. This client in France moved this memorial out of Paris where it happened and asked for it to be in the countryside where you approach it very softly and the lines organically move you in. So, of course, we have in context in these relevant spaces, symbolic tools to use. And I just want to hit again, in Oklahoma City, there are 168 empty chairs, similar to the one in Berlin, 19 smaller representing the children. Here in Norway, featuring sort of the 91 so-called witches burned at the stake 300 years ago. There is a long wood frame enclosure, 98 windows, and then over on the right, you know, a little sort of outhouse that features a burning chair, very symbolic. And also relevancy, architects have to do due diligence. We have to know what the culture sort of respects and wants. So of course, flowers and observing death, the Protestants use flowers, the Jewish discourage flowers. So these kind of research we always need to do. And we know processing collective grief and trauma is done in a variety of ways. So for architects, one of the main points when asked to do a design for sort of one of these public endeavors is really to step back and use what we call is the architect's concept. And the architect's concept is the problem statement. What must we solve? And at any school of architecture across the country, perhaps different than medical school, the students start off right off having to learn to define the concept. What have you really listened and learned? What is the problem and what do we need to solve? And so I'm just going to hit some New York City. The underlying concept, according to those architects, was to design lost lives cannot be regained and can only be remembered. And so the symbolism is the pools never fill up, and then around it names all the victims. In Vietnam Memorial in Washington, D.C., very linear, of course, but Maya Lin, as you perhaps know, was a student at Yale University College of Architecture and simply sent into the competition a quick drawing before she went off for Christmas vacation, and she won the competition. Her idea was to create a dent in the earth to denote the agony and fatalities that were brought by the Vietnam War. So her concept denotes the agony and fatalities. In the Oklahoma City Memorial, I want to bring it to your attention how, though the architect comes up maybe with the original concept, you know that grief and trauma have moved through transitions successively when the community takes over and redefines the concept. And so I want to show you this. The key plan here is Oklahoma City, if you don't know, is in this heartland. You know, we never saw this as all possible, but here it happened to us. And so the architect's tools in this project, you know, he entered entry gates. You'll see water to reflect. The chairs symbolically, we know there are viewports. We're going to talk about those, the lines of the plan, and also the borders. But what did the architects decide was the original concept so that all the pieces of the design would come under this major concept? And they came up with to commemorate each life that was lost individually. So of course, they added the silence, peacefulness, the atmosphere, and you would see the liquid mirror. It gives a sense of reflection on the tragic event and that there is life afterwards. As you look into it, you see yourself. And of course, the nature of the pool also portrays this tranquility and misery at the same time. The individual chairs allows the relatives of those that lost to continually come to their chair. And also the detailing of the light and darkness takes away the gloom at night and is more hopeful. And so we have a tree that they thought they had lost on the site after the bombing, but they came in and took very good care of it. So it portrays resiliency. And you think life lost individually only meant people, but in this way, it encompassed nature. And so this was also done in New York City, this sort of idea of bringing back nature that was very hit hard. But also at the Oklahoma City bombing, they started to bring in the rescuers orchard and added green, of course, the color green, to add soft and giving lines. And they put a pattern around each of these trees, edging and around the trees to keep things safe, sort of a symbolic idea. And they made all these native, but also foreign species to symbolize all the rescuers from all the globe that came to help the community. But healing isn't just the architect's perspective. It extends beyond that. And so over time, the Oklahoma City Bombing Memorial had to add a wonderful big blackboard so that children could come that were still alive and add their thoughts and be active and be part of this memorial. A survivor's wall came into, they took remaining pieces of the building and then put up these plaques of names of survivors that made it through with the help of these rescuers, medical or policemen or even volunteers. And so the idea of maintaining the wall seeks to sustain the honor. And then the temporary fence that went up as there was a construction site underway. And it was originally meant to shield the area from chaos, but people suddenly started items on the fence to show their affection from the community. And the fence is still permanent now and interactive to this day. And so if we were to step back and look at the concept that the transitioning community public has today, because they could be part of recovery, was to say, really, the concept today is that for this site is to commemorate all that were affected by this event and transition from this site with hope and inspired realities. And so in concluding, the challenge, I say, is that for us as architects, grief and trauma is a transitional process which forms a part of life. And we know that different people display trauma and grief in diverse ways. So how in the public realm can we be helpful? So I would oversay architects and landscape architects designed to reflect the purpose of the space, to create a connection between the people and the space event it represents, for people to connect with the deceased even in their absence, to enable physical space to commemorate, but also to help those left behind to move out with hope and inspiration. And so for each of you, in conclusion of this talk, of course, my I have a hope, a big hope for this talk for each of you, is that you will always consider architecture to sit at King Arthur's round table in helping build, and move out of trauma. Is sort of an awareness of stronger senses, eyes, ears, and hearts for these spaces when entering these physical spaces. But also to realize that we can help move people in sort of a larger mass, explore grief and trauma, touch physical spaces for the private, the individual journey, and the public. And that loss produces, and the chaos, ritual, and ceremony that helps people fill the void. So again, I want to hit the tools of an architect. So sort of running parallel is setting the stage. We can set the mood. We can detail physical spaces to be impactful and mindfulness, and to bring out your senses. We can help frame the views to move you on out, or to accept the grief and talk about it. And we can put it in context to make it relevant. We do our due diligence the best we can. We can advise you on urban or the topography, and we can talk about what is the major problem here, what is the concept. Here are my references, and then I open it up for thoughts or reflections. Thank you.
Just a wonderful presentation. I truly enjoyed it. And it dawned on me that the themes that you put forth have stretched into our language as well. In Masonry, we call God the great architect. Rudyard Kipling refers to our devotions in architectural terms. If you can watch the things you gave your life to broken, stoop down and build them up with broken tools. And so these themes are universal even in the language now. So I just greatly appreciate the presentation and meaning that it has for me personally. I want you to talk a little bit about your thoughts about what is the architect's role?
My apologies.
Not just uplifting us all in a healing manner, but educating us in a somewhat, at times, painful manner.
I'm sorry, I got disconnected. Could you start again?
Absolutely. I said, what is the architect's role in not just uplifting us in a healing manner, but also educating us in somewhat of a painful manner? And to be specific, there are architectural pieces where we grieve actively and painfully at. The Western Wall.
Yes.
Okay. And so there is this dual nature of architecture, and it part uplifting, part memorial and educating into the future.
Yes, so such a good question. You're specifically asking, how could we actively be engaged even before these memorials are created or asked to be designed, correct?
Yes.
I think a lot of things that we have been, for instance, where I've been sort of focused recently is Oklahoma has the highest women incarceration rate. And we have found that in trauma, which most of these women have been raised under, that they react violently to the back of their brain. They use their back, so they're just very emotional and right on. They have not learned to use the top of their brain to be more logical and slower to make some logical decisions. So some of the things we've been looking at are in cell designs, making the viewport out of the cell more broad so that they can see people coming so they can slow down their reaction. We've also begun to look at colors that are more hopeful and more calming for these very reactionary inmates. We've also really begun to look at the ability to have sort of a borderless feeling of inside and out to nature, so that light is more on a rhythm and not so closed down, and that there's a natural pattern so they get a good night's sleep versus being, you know, all over the place. So just some variety of small features that we, I'm just even changing some of the colors of the clothes of the staff or the inmates to be more. So I hope this is helpful. Yes?
Yes. Frank Lloyd Wright had a problem with light, did he not?
Really liked.
I just thought I'd put that out there.
What a good question. Thank you for letting me.
Not too connected to the client, was he?
Never. You know, I was hearing your earlier talk so I could understand sort of the context of this conference, and I was thinking how often architects, you know, are ego. And we really had to learn bedside manners better. Louis Kahn, yeah.
Yes. At the Vietnam Memorial, you will notice that the pavement goes in descent, and then we reemerge at the end of the wall, right?
Yes.
So it is a decline in the decision-making, the moral thinking of man that then reemerges, a theme that carries out right through Yad Vashem in Jerusalem, right? The descent and the re-elevation of man at its height, sensibilities toward our human instincts. And I think that brings out the linearity of that memorial quite well.
Thank you. Yes, it does. You know, I have visited that site so often, but I've never put that in my talk, but it's so true. You really descend and then you
descend and you elevate.
Yes.
You pointed out something that I had never noticed. As many times as I have looked at that wall and saw my face, I never pinpointed the reflective nature of the architecture and what it would mean in terms of the morning. It's important.
Hi, would you mind expanding, Dr. Williams, on your connection with poetry? I found that particularly elucidating. You recited Kipling. Can you?
Yeah, Rudyard Kipling's poem "If," where he talks about our human investment as broken, as though the human investment was physical. So much of our human investment, of course, is emotional, right? But he talks about it in broken natures, and then he talks about our capacity to if these things were broken pieces upon the ground, to stoop down, to descend, and then to use tools to build them up. And the ability to do that, to go through that process as being revealing of a higher nature of a man or human. And so these are building terms for very much emotional themes. So.
Yes.
Well put. Thank you.
Dr. or Professor Callahan, it's great to have the Perrys helping us out in so many ways.
Yes.
You gave us, and to me, a completely inconceivable, or at least I'd never conceived of it before, introduction to how architects approach such a challenging task. I wonder if you have any of these examples you've shown, ones that you thought were particularly successful or maybe uniquely adapted to the particular circumstances being addressed. I can't say favorite somehow.
Yes. I really feel like the New York City Memorial has not, when I have visited it recently, it seems that the community has not totally engaged in it on a personal level. It's very monumental and what I call hard architecture. There are, you know, trees and so for that reason, I love the Oklahoma City Bombing Memorial simply because you can see how the community has embraced it. And even today, you know, even many years later, it is so actively used by all people that work and visit downtown. It's, you know, they have some data collection and they demonstrate it's more used by community members than visitors. So in that way, I love that. I do, you know, the Vietnam Memorial, I feel is very successful. And perhaps that's because a student designed it and it just didn't have to be a coffee table architect. And I think that in itself shows you hope. You know, that there can be so much of an emotional participation at any level. You know, I extended sort of the global world for you in this talk because I just wanted you to see that this idea of trauma and grief is a global one. And that so often I have found just in my work with these inmates that working with a diplomacy lab, that so much of our work is really global and we can help each other.
What is your thinking about, I'd like to ask a question if we have time. What is your thinking about the Nkrumah Memorial in Ghana? How successful do you think it is? What is your, and what do you have to say about that? I've seen it.
You have, and what are your thoughts at the moment? Or have you, are you thinking it's successful or?
I think it is. I mean, it's sort of, has a longness about it. It's not wide, and it's forward, like you said, forward thinking, and then it slopes, and it has some of the traditional culture you were talking about. You have to have good bedside manner. Well, a lot of these shapes are in traditional Ghanaian culture, and to me, it's very successful. But I never took a critical eye at it. That's why I wanted to know what your thoughts were.
Well, you know, I haven't actually visited it. So it's more from a perspective of trying to dissemble it to share. I would trust more in your feelings if you think it's successful. You know, yeah. If you're
well, one day when you see it, I really will like, maybe we meet again. I'd like to know what you think.
Yes, thank you. I will do that.
Yeah.
And I'll try to get specifically there.
Yeah, you would enjoy it.
Let me say this about New York, because I think it's important. the New York Memorial is hard to engage, whether you're from New York or you're not. I've been there several times. And the actual monument that I think for me is more emotional is the tribute to the Northern Invasion with the Special Forces soldier on top of a horse that's rearing up on two legs, which has now been removed from the towers. But the coldness, the massiveness of the New York Memorial, it does exactly what you say, Dr. Callahan, but it fails, I think, to take into calculation the home base. New Yorkers are hard to penetrate. That's a hard crowd. And I don't know that the colors or the themes appeal in mass to them greatly. Each time that I'm there, I just don't see the level of gravity to it as I see in other memorials that I visit often. And so it was a difficult task to start with. And I don't know what to do except put a New York Yankees sign or a Giants sign on it and see that'll help them a little bit, but they're a tough crowd.
Got it. I just, when I was up there recently on a field trip with my students, what shall we go visit? Here, this is an architectural, landscape architecture, new. Nobody wanted to visit it.
Yeah.
I don't know.
It's not Baha'i. It's not the Baha'i Temple on Northwestern's campus. Let's just put it that way, which is an elegant architectural feat for reflection.
They wanted to see the new sort of island, like Petals in the Hudson Valley, in the Hudson River. So you know what I mean?
Yeah.
Well, in some
But
ways,
if we go to Washington
Dr.
D.C., they
Pandya's
all
talk,
want to
yours
see.
raises so many issues that you're going to have to come back. And regarding Dr. Simpkins' assignment, you only have 364 days remaining. So
how kind.
I hope you'll be able to complete that. And I am noting that Dr. Kelly, if you can see his thumbnail, in honor of your talk, he's participating virtually from the Sagrada Familia, another riot of color and elegance. And as far as architecture, I'm slightly less dumb than when I entered. Thanks all to you. Do we have any further questions for Professor Callahan and the larger Perry team? Well, thank you. This is the conclusion of the morning component. We'll be meeting again at 3 o'clock in the afternoon Mountain Time. Gary Schwartzbauer from Shock's going to talk about neurotrauma. Simon Talbot, our favorite Kiwi, is coming back from the Brigham to talk about hand injuries. Dr. Simpkins, who is going to be presenting the first of his two talks, this on the interim results of the clinical trial for resuscitation. And as we learned, we got a long way to go in shock. Dr. Kelly is going to be talking about rural surgery, and I've heard a little bit of the talk. It's great. Mahesh Prabhu is going to be presenting 3,000 consecutive cases of cleft repairs done by him. A monumental achievement. Dr. Tompua Mara is going to be talking about regional anesthesia and ultrasounds, original work there. Oh, wait a minute, I skipped. That's tomorrow. Going back to mitochondrial plasticity, we're going to leave the way we came in. And Inigo Sanmalan, who again worked with Dr. Lindberg in Colorado, is going to talk about some of his work on mitochondrial plasticity and how it affects health more generally. And it is riveting stuff. It will change the way you think about healthcare. So I'd like to thank everybody for coming along with us. I appreciate your patience with sound issues, most of which were my doing. We need to find an interlock between the mic and speakers, and I apologize for that. But we do, as they used to say, as Ed Sullivan used to say, we've got a really big show coming up this afternoon, and we'll see you again there.